Bore da I chi gyd, a croeso I bwrdd iechyd Prifysgol Aneurin Bevan. Good morning, everybody, and welcome to the meeting of the Aneurin Bevan Health Board. I have not got COVID, but I have got a bit of a chest infection. So if I have to leave the room, I've asked Shelley if she would be the chair in the interim, and she's very kindly agreed to that. Welcome to those guests attending both in person, and we're very pleased to see you, and those who are joining via Teams to observe us today. The meeting today will be recorded and published on our website for viewing following the conclusion of our meeting. And later today, we will be holding our annual general meeting, and the details of that are on our website, but it will start at 2 o'clock. And as you know, the annual general meeting will cover the performance of the organisation during the past year, and questions are welcomed in that context. Thank you. We will be welcoming a number of people today. Linda Joseph, the Deputy Regional Director of SICE, will be coming. Gemma is not very well. Tanya Strange, Head of Nursing Patient Centred Care, who will be dealing with the patient story, and Karen is here, the Director for Communication and Engagement, who will be dealing with the engagement strategy later on today. Are there any questions before we start? No? If not, apologies for absence. We have Tracy Daskovich, Pippa Britton, Martin Blakeborough and Richard Clark. Everybody else looks as if they're here, so that's good. Okay. Any declarations of interest below in connection with any of the agenda items? No. The draft minutes of the Health Board meeting held on the 19th of July for approval. Are there any amendments to these? Is everybody content with them, a true and accurate record?
Yes.
Okay, thank you. We adopt those. And we've also included a summary of the board business which was held in committee on the 19th of July, the 9th of August and the 31st of August. Is everybody content that that is an accurate record of our debate? Thank you. The board action log for review, Rani.
Thanks, Chair. So the action log included today provides an update on 4 actions arising from previous meetings. 3 of those actions are scheduled to come forward to the board at future meetings, and 1 action in relation to commissioning and place-based care has been deferred in light of other pressures, and we'll bring forward an update on that in due course. Each action has an update included within the paper, so I wasn't going to go through each in detail, but happy to pick up questions with action leads if there are any.
Does everybody get that? Yes, Shelley.
I just had one on the second action down, which was regarding the annual complex care. It was obviously due to come back to September, but it's been obviously delayed for the time being. I just wondered if we could have a date when we think we're going to get that back. I'm assuming there's no impact in terms for service users providers in relation.
No, it's not impacting. Sorry, Shelley. It's not impacting at all from a service user or provider sort of issue. We are doing quite a lot of work on CHC sort of more generally, so I think it would be worthwhile us bringing an update. There's an independent review that's currently been undertaken, and we're just in the process of setting up a CHC. So I think it's definitely worthwhile bringing that back to a future board. Oh, definitely, yes. So perhaps we can have an update at our next meeting. Yeah, I think sort of probably we could do November. I think a reasonable. That's all right. November. Yeah. Okay, so agenda that for the November meeting. Are there any more issues, comments, questions? No. Thank you. The report on sealed documents and Chair's actions, Rani.
So this paper provides the board with an overview of the use of Chair's action and the application of common seal between the period 4th of July and the 6th of September. During this period, there have been 2 applications of the Health Board seal, and the detail of that is set out within the paper. And 1 matter has been agreed by the use of urgent Chair's action, and that is also set out within the paper. The board is therefore asked to ratify the use of urgent Chair's action and application of the Health Board seal.
Are we content?
Yeah.
Happy to ratify that. Thank you. Chair's report. apart from my usual bilaterals and visits, I've attended three ministerial meetings, one of which was relating to an urgent meeting about the financial pressures being experienced through the health service in Wales, at which the Minister asked us to prepare additional plans in order to achieve further savings from those that we had planned already to get back to our estimated position, which we did. It had to be done in very short time scale. And I'm very, very grateful to the hard work that the executives and the teams underneath that have put in to assembling a sensible and cogent response to the Minister. We await to hear what the final decision will be. I also attended a ministerial meeting which was convened on winter planning with local authority, regional partnership board and health boards, which was held earlier this week. And the Minister obviously was well aware of the fact that winter would create even more pressures on the system than exist at the moment, and we've already had significant pressure, but that we obviously had to be planning well in advance for winter, which of course we are. And she was very keen that the local authorities and the health boards worked absolutely collegiately together on any solutions that would come into being, together with the regional partnership boards. I await the minutes of this meeting, but certainly the imperative, as we all know, is to ensure absolute patient safety and access in very difficult circumstances, because we know that disease is circulating at the moment, particularly respiratory ones, and that we need to plan extremely well and estimate well the numbers of people who will be coming in. So that was quite a helpful message from the Minister. As I say, I've done a number of visits, but particularly I visited Neville Hall to talk to the staff about the issue of the rack and to see it for myself, which indeed I did. And we will be having a further discussion about that later today. For the RPB, I attended their leadership forum as I chair the RPB now, which looked at performance, resources and governance. And as you know, I asked that a governance review should be undertaken for the Gwent RPB to ensure that with its extended role, it was still fit for purpose. And the RPB received that report at its last meeting last week. And I've set up a small working group chaired by the Vice Chair, Jason Hughes, the Cabinet Member for Social Services in Newport, to take forward the recommendations within this report and come back to the RPB with their suggestions and their plan for the way forward. We obviously talked about the resources associated with the RPB. We have asked for guidance on whether or not the tapering arrangements that apply to the resources provided for regional partnership boards will be implemented next year. This will have significant effects on the planning within all the statutory bodies, all 6 of them. And so we do need to know as soon as possible, because the statutory bodies will be formally consulted in order to determine what they are and are not going to keep and what services they might have to alter as a consequence. So it's really an imperative part of the work. The RPB also, all of them, met with the ministers, and the primary focus there was about children's services, the Eliminate agenda, the type of scheme that we have in Gwent, which has proved to be most successful in terms of access to support and care. and the general issues surrounding the provision of children's health and social care services. And that was quite a positive meeting. We've had a couple of meetings of the chairs of health boards as well, where the issues that we have discussed largely focused on finance and how people were managing the financial situation, which applies to all of us, the quality of our care, and whether or not we should join up a little more to be able to provide possibly better cost-effective care together. And we've also started to discuss the 10-year plan because at the moment the last plan is coming to an end, and we really need something quite radical to replace it. I was grateful for the discussions that we had as a board last week. Was it only last week? Mm-hmm. Last week, feels like ages ago, on what our proposals for a 10-year plan could be before we go out to public engagement to really find out and to allow the public to plan with us what services they believe they will wish to receive in the next 10 years. But you know, we recognised as a board that we had to be quite radical and really boost the community services to enable people to access care effectively. So that's basically what's been going on. The weeks seem to have belted past, I have to say. And I'm very, very grateful to our staff for coping with the huge demands on their services and the care that they provide. And also to our executives who've worked tirelessly over the last couple of months in the realms of quality, finance, and governance. And I'm very grateful on behalf of the board to them for their hard work and for the sensible advice that they are providing. It isn't going to be easy, but the board is here as a united board, and we will strive to do our absolute utmost to deliver good quality, timely care to people within the Gwent area for the future in conjunction with our partners. Are there any questions? No? Thank you. The Chief Executive's report.
Thanks, Chair, and we've covered quite a lot of what's been going on, so I won't spend too much time repeating it, but I think just to reinforce the significant focus we've all had to put on the challenging financial context over the last couple of months, both at a national level and a local level. And as you mentioned, there's been a huge effort of staff across the health board, and we pick up the clinical advisory board, but putting in a structure that really ensures we look at the choices and options we've got through a quality and safety lens, and we really understand the impact of our decisions. We have tightened the control environment because our costs are still running quite excessively above even the plan, and therefore we've had to do the kind of central control, which it's important we manage the impact and there's no unintended consequences. So we really are trying to be pragmatic about that approach and just ensure that we've got transparent risk, so we understand some of the risks we take in some of those decisions. There's been a really positive response from staff where we've encouraged staff to come forward with ideas of how we can spend our money differently, and there's been over 300 responses from staff that we've been collating and picking up the themes, and then we're trying to kind of follow that through now in terms of feeding back to them and taking some of those issues forward. We've formally been notified from Welsh Government that we will be putting enhanced monitoring for planning and finance, which is a consistent picture across all the health boards as part of the escalation framework because of the financial position that we're in. That will result in us obviously just having further meetings with Welsh Government to give them assurance around the action we're taking. But whilst all this is going on, we've continued to keep our focus on continuing to meet the increase in demand and also continuing to try to recover from particularly around waiting times and address some of those planned care targets that we've set out as well. And I think going forward, I am trying to look at how we can pull more of a quantitative report together around how things have changed in terms of demand. There's many services just been speaking to in the last week or so where the numbers of referrals compared to what we were seeing in pre-pandemic are quite significant. And trying to pull that together into a greater understanding of why we are under as much pressure as we are will let us help in terms of if we got the right actions against all of those. There's been quite a lot of public and media interest naturally in the health, and particularly for us around the financial challenges, the RAF that we refer to and is on the agenda later, proposals for a minor injury unit at Neville Hall, and we have the HIW maternity report as well that was issued, which, whilst there were some issues identified, was generally a good balanced, positive report for our maternity services, with any immediate issues addressed. Obviously, some concern around there's been an increase in COVID prevalence that puts pressure on the system, and we've seen that with some work at the national level that they're monitoring this new variant just to ensure that our vaccination programme responds to that. And even the recent hot weather, particularly seen in early September, we see the consequence of that, particularly about 10 days later, heightened, increased demand around respiratory disease, and we've definitely seen that in the last few weeks with extra pressure on the system. So trying to do all that and maintain staff morale is a key priority for us, because we realise how hard everyone's working, and the pressure on the finances, is something that adds pressure to the teams. But I've been out and about quite a lot again in the last few months. I visited the neonatal services, the health team in Blaen y Gwent. I went to the mental health ASA house on Monday, which is around trying to help people step down into their own accommodation. Been to Aneurin Bevan, Tredegar, and attended the Mental Health Wellbeing Day. And, I still continue to be blown away by the positive and energetic effort of teams who are always looking for new opportunities and new ways of doing things despite the challenges. And we have made some real progress around areas of recruitment. We've seen a continued reduction in our agency for healthcare support workers and our qualified nursing. And you can see the positive impact that has on teams where we manage to do that. We've still got areas that are challenging, but we have made some really good progress in a number of areas. So a significant focus on that in the next few months. And I did have the pleasure, I'd like to end on a positive, at the South Wales Argus Awards last Thursday. Like Leanne and myself and James attended with some other colleagues, and our staff were nominated for a number of awards on the night, and with quite a number of winners as well, which was really great to celebrate the successes and for them to get the recognition they deserve for some of the great work. So it was a real pleasure to attend that as well and celebrate with them. So on that positive note, I leave. Thank you.
Thank you, Nicola. Are there any questions to Nicola?
Well done.
Yes, a lot of hard work then, and hard work for all the staff. Okay. If we can move on to section 2, could we take the patient story first, as I don't think Linda's with us yet. No. Tanya.
Oh, yeah.
There we are.
Morning.
Morning.
Morning. Thank you for inviting me along. This is a very short patient story to demonstrate how we're listening to patient and carer feedback and making positive change. I'm aware that some of the board members may have seen Paula's full story before, but this is a lady whose husband came in during COVID, raised similar concerns that we've heard over a number of years around communication, inability to visit. She felt pressured about needing to make end-of-life decisions on the telephone, as a lot of people had to at that time. And when she was able to visit, she raised some concerns around the fundamentals of care, particularly around oral care and weight loss. What Paula wanted from sharing her story was that we learn as an organisation, and she certainly wanted to see better staff awareness, if you like, around how we care for people with dementia in a hospital setting. So hopefully Bryony will be able to play the short clip. There are some examples on there of what we've done based on elements of Paula's story, and I'll come back in after that and just give a bit more of an update on the actions that we've taken.
Thank you.
I think he must have felt absolutely betrayed and lonely. I had many mixed messages after these calls. Next morning I phoned. No one answers the phones. I had one very kind lady phone. Alan was asymptomatic. I was so very relieved. I'd been told that they didn't have any iPads or cordless telephones on the ward. She put her own mobile phone in a polythene bag and said, "I'll let him talk to you now." A week later, I was phoned early one evening. They couldn't do any more for Alan, and they wanted my permission to just administer palliative care. I really couldn't give an answer. I asked if they could phone me back tomorrow. I needed to talk to family. I was told this was not the family's decision. This was my decision. Did Alan give up because he couldn't swallow? It was too painful, maybe. Did he just decide he'd had enough? I don't know. Dementia patients respond, but they take time.
Oh, there she is. Anu.
Hello, sorry, I've got a blank screen now. So, there we are. Okay, so if I just summarize from Paula's stories and other stories that we've heard from people living with dementia, we held a learning event with the clinical team. There were 6 wards involved in this gentleman's care. It was a very positive learning event, and those teams have shared with their wider teams. We've changed the whole focus of the dementia inpatient action plan. There's a much better MDT focus on the fundamentals, and Paula is actually an invited member to the inpatient dementia group. We've relaunched John's campaign and encouraging visitors to come at a time that's suitable for those. Through workforce reconfiguration internally, we appointed a dementia specialist practitioner. They are working with the clinical teams on the ward, supporting the learning and actually celebrating what they've done to improve dementia care. We've now got dementia training as mandatory on ESR, and dementia awareness is now part of the new registrant induction. Through Welsh Government funding, we've appointed 3 Mental Capacity Act specialist practitioners, and again, they work side by side with clinical teams, supporting with issues around consent, best interest, etc. One of Paula's main suggestions was that people, anybody going onto the ward, staff, needed to recognise at a glance that somebody had dementia. You would have seen as you walk around the wards that we've got new bedside boards now. That it's not just for people with dementia, it's for the safety risks of anybody that might be in our hospital bed. And we use the dementia daisy to indicate whether that person has dementia. We've worked with the oral care leads, and we put additional training in for staff around oral care, and parts of Paula's stories has been used for staff training in regards to that. We've got the meaningful activity training program, and more staff are attending that. You'll be aware that we've got dementia champions and dementia companions from the dementia annual report. They are supporting people side by side who are living with dementia on our wards. We have a lot of bite-sized learning taking place now, delivered by our own specialist staff. So where Paula, for example, raised issues around hydration and nutrition, we have dietitians who come in and do some bite-sized learning for clinical teams around that. We've also developed with people living with dementia and their carers an anticipatory loss training program, because I think what carers were telling us was, one, they didn't really always know how the condition was going to affect them, but that we didn't always understand either how the condition could deteriorate so quickly. We've just started a number of dementia roadshows. We've launched publicly on March the 1st a hospital charter animation, so that all the public know what our intent is in regards to improving dementia care in hospital. And Paula herself is now one of our experts by experience, and she has been involved in recruitment, so she comes to the interview panels, and I'm very pleased to say she was actually on the interview panel when we appointed the nurse director. So that is a summary of the positive actions we've taken through listening and learning.
Thank you very much, Tanya, and thank you again to Paula for sharing her story with us and allowing us to make quite radical changes to the way in which patients can be cared for. Are there any questions? Shelley?
Just with the training, I think it's absolutely fantastic, all the work that's going on. So with the training, I know mandatory, so I wondered on ESR, where are we with that? You know, so what percentage of staff are actually doing that? And I understand as well with the bite size, I think that's really good, particularly if it can be delivered like on the wards, so that people don't have to go out to the workplace. I think that's really good. I wasn't sure where Paula's husband was when he passed away. Was it in Royal Gwent? Yeah. So if you were to go into Neville Hall or one of the other community hospitals, would we have the same standards of service and training going on in those different areas as well?
Yeah, it covers the training covers all areas, and even though we're focusing very much on inpatient dementia care, people from the community can join that. But yes, it's open to all staff in all hospitals. The dementia champions as well. We've got representation from all hospitals. In relation to ESR, I'd have to go back and check our statistics for that, but I know it was quite healthy when we reported back to Welsh Government on dementia training back last year, but I can send the current position out for that.
ESR obviously is the electronic staff record, which records that all training. So it's all right. It's just that the public won't know what it is.
No.
Thank you.
That'd be helpful. Thanks very much, Tanya.
Okay.
Anne, sorry, I don't know if you can see me.
Could I just add, and obviously we've taken the engagement with patients on a step further. So you'll all know that we agreed to start a PAL service that goes live. We've recruited, that goes live in October. And again, I think it will change the nature of the interaction with our patients and their families, particularly when they're finding it hard to communicate with us or they're finding it hard to get the information we've. So we've gone a step further, I think, with the PAL service from the patient liaison service, and the patient liaison service is now moved into Tanya's team. So we've got that cohesive approach to how we engage with people. And I have to say, I think the work Tanya has done with Paula and with, our teams across the Health Board on dementia is excellent. Tanya's done a fantastic job, and I'm really proud of some of our services that we have around dementia care.
Thank you, Jenny.
Thank you, Jenny. And I'll say it's the team. And Amanda did win the Royal College of Nursing Award for the care of older people for a lot of this work. So we're so proud of her.
Good, lovely. Good to hear. Any further questions? I think it's really important that we revisit some of these stories to make sure that we have made changes as a consequence. It's really important. Okay, thank you. Thank you very much, Tanya.
Thank you. Bye.
Thank you.
Bye.
Bye. I don't think Linda Joseph is here yet. No. If somebody can keep a watch out for me, and we'll come to her. Yeah. So can we move to 3.1? Performance and accountability management framework. Anna.
Chair. So yeah, the purpose of this paper is to present to the board for approval the performance and accountability management framework. It's quite a detailed document. The purpose being to provide clarity on how we approach accountability and specifically delivery of performance and the ambitions and standards we've set ourselves through our plan. The document sets out the principles that shape our approach. It's not just about the reports or the meetings, it's about sort of the mindset, the actions in between the reports, the individual, professional and personal accountability. But it does set out some of that architecture that's required to be put in place to provide that sort of proportionate assurance. It introduces formally the escalation framework that you'll see in section 6, and this is that will be applied, the triggers that would necessitate the initiation of the framework and the responses that would ensue if a division or a corporate department was put into escalation on a particular domain. I do think it's important to stress all these elements are new. We have a number of these elements already in place in terms of the review structure. You'll see from the approach we've already taken to mental health. It's part of our practice, but this framework sort of formalises and solidifies that and introduces new elements in terms of corporate teams and more specifics about the beta meetings, the inputs and the expectations. In terms of the scope of the framework, it puts into context the accountability framework from Welsh Government Board right down through to PADRs and appraisals, but it really does focus on that middle bit in terms of the divisional and corporate accountability piece. So the bits, without going through the whole document, I just wanted to bring to colleagues' attention were the strengthening around the arrangements, the monthly meetings and the focus. I mentioned the escalation approach in section 6, which introduces an enhanced monitoring escalation and then a special measures. Also want to note as well that because this is new, there will be learning. We have looked at other organisations, we have looked at best practice, but there will be learning as we apply it. And it's important to note that an update of the national escalation framework, I can't quite remember the title, went through the chief exec's NHS leadership board, yesterday. So we just need to sense check. And on initial looking, it doesn't sort of change our approach, but I think it is an important context for our approach. It's important that the framework can remain agile in terms of inputs into those meetings, depending on current context, current risks, any new standards or delivery requirements. And we have, as the cover paper identifies, there are some areas of further work as we move through implementation and we allow this approach to embed. So I'll leave it there, Chair, open for questions, but ultimately would ask that we can approve the framework for implementation.
Thank you. Thank you. Any questions, Paul?
Could I ask the implication of the national escalation of the finance modelling, which we've received? What is any impact of that on this? Because obviously, if you've got a plan, then suddenly there's got to be reduced budgets in areas. How would it affect performance? I just wondered whether that's been mapped against this model.
So this is a framework. So I think, again, subject to us using it and us testing it, it will pick up the context of the plan because the framework is there to track and give oversight of our plan commitments, whether that's the plan how it addresses financial challenges. So Rob and I have worked closely on some of the financial triggers that are in the escalation framework. So I think, and unless the colleagues, I think it will stand up to that test. We just need to be applying it because that will be the context within which. So it will determine the inputs into the meeting where teams are against delivery, against their financial commitments. That will form a key feature of what goes into those reviews. So
just joined up then, in effect.
Yeah.
Okay.
Do you want to add anything, Rob?
I just support it's multi-dimensional, and obviously I know key indicators and finance. I'm sure I didn't say is a big one at the moment, so it factors that in a balanced way, and the triggers allow a bit of tolerance before the step ups in the escalation apply.
Ewan? Oh, Shelley first, then Ewan.
Probably not shouldn't answer the first question. I've got two questions or queries. With the structure, I wondered if there was a role for the audit committee in the overall monitoring, but not monitoring, but if you're reviewing it and having input, you know, so what, because that's not actually on your chart. And the other thing was, there's a mention as well about the signing off of budgets, accountability letters. I know in the past I've asked about this because you can issue a letter, but quite often they haven't been signed. So as part of the escalation, I mean, is that part of the overall accountability framework, strengthening that element? Is that, you know, those were my questions.
So on the first, the committee, I'm happy to be steered on this. I think, and in an ideal world, apologies to the Finance and Performance Committee, this would have come through there first, but we were doing some of the development work still within the organisation. So my assumption had been the Finance and Performance Committee, but happy to be guided on that. And maybe there's a
reference for the committee to oversee the framework for which it's managed.
But maybe just thinking now on the spot, it will be a future audit. We would want an audit to do on its application, and then it would come into the committee. So that would be really helpful for us to learn from that. And the point about the division, you know, about accountability letters, it is mentioned in there, I'm sure, because it's a real big important part, and lots of work has been done, sort of guided by Nicola in terms of that, and them not just being budget accountability letters, but in terms of broader expectations around individual objectives and alignment to the commitments in the IMTP. So that is, I guess, the point about like the sign off of them and or otherwise how that features in triggering response. That's not, we haven't sort of addressed that specifically, but we can do that.
I think so. I think it'll be important so that all staff know exactly how this is going to operate and how it could affect. You want?
Well, Shelley's nicked a bit of my,
Oh.
some of my thunder on the governance side of it. But you mentioned that a lot of the controls we talk about here are already in place. And I think you mentioned already that the bureaucracy that could creep in with a framework like this. So how are we going to measure success of the actual implementation of the framework? So we're putting it in. This is, we turn around in a year's time and go, we put that in, this is what it's achieved.
I think fundamentally its purpose is to help us deliver what we want to deliver by providing that clarity of what the priorities are, what the performance ambitions, alignment to the plan. But there is something about being clear on the consequences of non-delivery as well. So I think success looks like improvement in our performance and delivery against plan, because we've sharpened up and focused on that delivery piece. But that's why we're putting this in place, is to improve and support performance development and performance improvement.
Okay, so we expect to see good performance.
I would on the, but
yeah. So how would we measure that then? So is it going to be on the financial side, or is it going to be on delivery of other things? How are we going to say, here's what we're measuring today, and that's what we're going to measure?
So I think the performance management framework is sort of quite a standard component of how we do some of our accountability. I think through its application will be critical for how we use it to drive the right performance and performance improvement. So I think what improvement will look like is its purpose is to drive performance improvement. If it hasn't, we need to be going back and looking at, if not, whether it be through the audit process, through feedback from those engaged in it. But why is it not?
When we talk about performance, there's obviously, I mean, I can pick on financial performance as a measure.
Well, hopefully you'll have seen in the framework it is, and as Rob said, it is multifactorial. We want to make sure that delivery is seen in tandem rather than isolation, because finance decisions could impact on policy and workforce decisions likewise. So that's why we've tried to make sure that it does integrate those elements. So when we're having those, whether it be the reports or the conversations about delivery, it is against all of those spectrums: financial, sort of operational delivery, as I call it, workforce, and risk management as well,
and quality.
Absolutely.
Yeah. So
all the domain.
Did we mention it's like a 6-month review process in the thing? So we bring that back to finance and performance in about 6 months, just to see how it's going.
Nick.
So just to, I suppose, pick up, this is about strength of the governance, isn't it, in terms of and clearer on accountability. So people are much clearer around what it means and how you can kind of reward those who are delivering versus support those who are not, and understand this. So I think there's a quantitative measure, so you can look at that. You should have a stronger control environment, albeit, you know, our performance is driven by many factors, not just because I put in a performance management framework. So it is important to understand what's driving it, and I think some of that feedback from the teams will be useful as well, and from ourselves in terms of how this then feeds the reporting up to the committees and to the board, because we should be able to report a much clearer position and understand our level of escalation of the organisation. So it's kind of multifactorial, I think. And as we said, we do lots of it, but some of this is not as robust as I think we need. And linked to Shelley's question on the accountability. So we've always had delegated letters, but I have changed it. So each executive director's had an accountability agreement, which has the objectives in of the things we expect to deliver, with the resources, with some specific IMTP targets if relevant, plus managing their own directorates of staff in. And so we've made quite good progress with that, you know, to do it earlier next year because we've got the framework in place. And then that's helped particularly Leanne then in terms of how she can delegate that now going down the divisions. And I think we'll be in a stronger place going into next year, having that done before much earlier, and then trying to get them to make sure they follow the same methodology right the way to the directorate. So whilst it's there now, it's not written down as robustly as I think, but I think we've got the framework now in place linked to this as we move forward. So we have got those strengthened accountability agreements, which was a key objective.
Some of that qualitative stuff might be interesting as well.
Look,
we've discovered there's a deterioration performance somewhere. What have we done about it, and how have we supported and strengthened up those controls?
And I think some of our teams will really welcome it. Other teams will find this a big change. So we will work with them with the right culture and support for people to understand what we mean by accountability, and again our opportunity to make sure risks are escalated and we support where needed early on and intervene where we need to. But then, you know, reward those who are.
Well, it's good learning as well. I mean, if you're spotting the performance is above, then why? There's the why question both sides.
Performance. Sorry, excuse me. Performance is multifactorial, isn't it, really? But I think just back to the point that's been made, but I think just to reinforce the engagement on the accountability and the sign-off has been enhanced, because it's not just now a budget letter that's been sent out, which is where we've been previously. And obviously, as you know, we're here to provide healthcare services. I think that rounded view of what's expected from a performance perspective, both in terms of service delivery alongside the financial aspect, that helps with the ownership, accountability and engagement with the divisions. And I think they've very much welcomed that.
Sorry, I was just going to say, I mean, I welcome the quantitative bit that's in there, because obviously we don't measure it, we can't prove it, kind of thing. So yes, I absolutely agree, it's multifactorial, but understanding which all of those factors are that we are trying to measure and improve.
So I think this sort of proved accountability with sanctions and incentives, such as described, they will fit well with the evidence that we're able to give as an organisation to the Ministerial Advisory Group on accountability, that everybody is taking measures to improve this. Paul?
And what I quite like as well is I think it's a great piece of work is that individual objectives will be aligned to the organisation's objectives, so that actually it's, you know, quite a thorough sort of journey, and that people are involved from the beginning and involved in the whole thing. So I think it's a great piece of work.
There are no more questions. Are we happy to approve and adopt this performance management framework, and we'll have a report back on it in 6 months?
Yeah.
Thank you. Thank you. Yeah. Performance, but thank you. And I'm advised that Linda Joseph is unable to attend today. So could we receive the report, and if we have any questions, we'll send those back to her. Are there any questions? Ewan?
It was just a minor note. It's the type of thing that keeps coming up in all reports around jargon in letters and things. If we have any specific, because it's always an easy one to throw out. Have you got any comments on anything? Yeah, jargon. Yeah, but what exactly? If they could pick up, you know, what exactly, which letters or whatever else, it does help us improve those services then.
Okay, Thank you. We'll do that.
Um,
Any further?
Yes, I wanted to talk to the device about the children and young people agenda, because although they got children and young people transition to adults, it's the health and social care aspect of children and young people. I quite like to ask about their work with regard to children and young people and surveying and finding out the views of going to schools and things. Just get an idea about how they're sort of capturing that agenda.
We can ask them for a report on that for their next report. We'll do
That'd
that.
be great.
Thank you. Any further comments to slides? No?
I think to say that I think it's a very good report, and particularly with regards to the new organisation set up, and to thank them and staff for all the work they're doing.
Thank you. We will do. Okay. Can we move to 3.2, the updated standing orders and SFIs from?
Thanks, Chair. So this paper presents the board updated standing orders and standing financial instructions as amended by Welsh Government. And these changes extend to the standing orders and standing financial instructions of our joint committees, WISC and WISC. The key changes reflect the implementation of the Health and Social Care Quality and Engagement Wales Act and incorporates updates to the model standard financial instructions which previously were communicated to us from Welsh Government. The changes are set out within the paper, so I won't go through those in detail. The revised versions also contain 2 local amendments, which have previously been agreed by the board, and these are in relation to the timing of issuing board papers, and the board previously agreed a variation from 10 days to 7, and the board previously agreed to hold the AGM for 22-23 by the end of October 2023, not July, as set out in model standing orders. The board is therefore asked to adopt these revised. Thanks.
Yeah. Are we happy to do that? Yep. Okay. Anything further?
No, thank you very much.
Good. Okay. 3.3, the clinical advisory forum in terms of reference. Jenny.
Thank you, Anne. I'll be brief because I think the terms of reference are fairly self-explanatory. So you will know that in a matter of urgency, we established the interim clinical advisory forum on the following the financial recovery discussions. A clinical advisory forum is a requirement for us as a health board, and the purpose is to provide the board with clinical advice and robust contributions from clinicians. We've also, as a health board, decided to ensure that we align the quality impact assessment process with the clinical advisory board, because that will clinical advisory forum, and their role will be to provide us with recommendations on significant financial recovery or damage. Their role won't be to say yes or no. Their role will be to advise and recommend as per the interim process we put in through the summer. We have to say, as we've reflected with the board before, the process was very well received by our senior clinicians, and it was a really robust process. Quality impact assessment is something that was started in England a number of years ago. It came on the back of the Learning from Mid staffs, and it is something being implemented on a Wales-wide basis. Our process differs slightly because we have followed the NHS England process, but we found on reflection that worked much better for us as an organisation. But the principles remain the same in terms of the All Wales process. So I'd like to recommend the terms of reference for approval and the permanent QIA process.
Thank you. Are there any comments or questions? You?
Sorry. It's just the appointment of the chair. Just seemed a bit of overkill that the minister, we went through it at a very quick basis. Yeah, sorry, yeah.
I defer to Rani.
I'm just here to say for clarification. So we should have had this anyway by the sound of it, should we?
Yeah, so it's one of our required advisory forums to the board, and the requirement for the ministerial approval of the chair's appointment to the board as an associate member is required to be endorsed by the minister.
It wasn't called the clinical advisory.
It should be called the healthcare
It's the healthcare professions forum, and they are a statutory part of the board.
And then the other way around, I think we can remove someone if they don't turn for 6 months. Seems a very long time for.
That's the same as board members.
That's the same as
Yeah.
board.
Oh, is it? Well, we get 6 months from that.
Yeah, don't take the opportunity.
It seems a long time for us, to be honest with you.
It's set out in regulation.
Yeah. I think we're a little more loose. If you let it go. Yeah. Okay. Are there any further questions?
Yeah.
Yes, Helen.
Thank you very much. So it's helpful to read this document. I just wondered, you've got lots of representatives from the different healthcare professions. How do you also ensure that you're fully representing all the activities of the health board and say the different hospitals, different bases, different specialty areas? Some things might get missed out by just not having a representative from that particular profession.
So that's why, Helen, in 3.3, we've said that we will potentially extend the group beyond the members listed to ensure that we have coverage of age group, geographical representation, and the appropriate professional opinions from all of the professions. So we have given ourselves the ability, or the chair, the ability to ensure that they have that representation in 3.3.
Thanks very much for the clarification. Thank you.
Thank you. Bill?
I've got to say, great to see this. I mean, it's formalising what we kind of had in the past.
Yeah.
It never really achieved its full potential, did it? But I'm just wondering whether we might consider the issue about how we introduce some challenge into it. I mean, it would be easy for this. I'm not saying it would, but it would be easy for such a forum to become very insular. And I just wonder whether we might consider drafting in maybe some expert views from outside the organisation. I don't know, maybe an experienced medical director from a high-performing organisation outside Wales or something, who might actually be able to come in and say, well, bring a different perspective to because it would be easy for this group to be very inward-looking, and I think what we need to be is outward-looking as well.
Tim's reference allow for that to happen on specific areas of work where you want to bring in expertise. I think the membership it's important that it is our internal arrangements advising the board, but absolutely support that approach where needed.
And myself, James and Peter will be in attendance to provide, I realise it's still internal, but we will provide that sort of internal challenge and scrutiny. But as Raleigh says, we can bring in expertise as and when.
Good.
Thank you.
Thank you. Just to explain as well, all the professions listed in the terms of reference in the membership are all have all Wales professional advisory groups that they're plugged into. So they do have that perspective beyond the health board that they can then bring back into the health board through the All Wales discussions. And actually, in many of those discussions are Four Nation discussions as well. And I know from my interaction with those professions, they're very challenging, robust conversations we have with the professional groups. You know, they are very good at bringing the outside view as the organisation. So, yeah.
Good. I think the issue of external challenge is really important. But it has to be owned by the people on the clinical advisory field. Look, if there are no further questions, are we content to agree the establishment of this? We have missed their influence for some time. Okay, so we'll go ahead and establish that. Thank you. Configuration of midwifery-led units. This is 3.4, and the outcome of public consultation and engagement.
Yes, so if I may, just to set a little bit of context, as you know, we have been in discussion with the board for over a year now around some of the service pressures that have existed in the maternity services. You'll know that I've provided clinical oversight and support, working with Leanne and her team to ensure that we have a service that is right sized to the needs of the population and in terms of being able to deliver a safe service. So the board agreed at a previous meeting that we would support the interim changes that have been made to the configuration of the birthing units. And we were asked to undertake a period of public consultation That public consultation is now complete, and we are in a position to confirm that there has been no significant objection to the arrangements. FLICE have provided a formal letter of representation, and we are now asking the board to approve the implementation of the preferred option. There would be two things that I would like to add. The first is that the board asked for a financial assessment, which was circulated, which we can recirculate, but there is no financial positive or negative impact of this change. The service change releases for whole-time equivalent midwives. They have been reinvested back into community services because that will enable us to provide better care in the community for women, more choice, and enable us to discharge women more swiftly from GUH, enabling us to provide safer care and improve flow in the GUH maternity services. The second thing to say is that we do monitor the outcomes from the maternity services quite closely. I chair, along with Linda Alexander, my deputy, an internal maternity service and neonatal assurance board that reports to PQSOC. PQSOC has received a number of detailed reports in recent months around, in particular, Embrace, which is around neonatal and stillbirths, and also still deaths, and also the prompt report, which is around safe staffing. So those reports have been through PQSOC. We also will be bringing in the new quality outcomes framework to go through PQSOC and board, some maternity indicators, which are the things that we know we need to monitor, but also are some of the national must-dos. So in particular, again, the stillbirth rate. So there will be outcome monitoring, but PQSOC receives in detail more of the information on the assurance from the maternity and neonatal assurance board. So, and we are asking you to note the outcome and to approve the implementation of the preferred option.
Thank you, Jenny. Questions, comments?
Can I just say, I thought it was a very thorough piece of work in terms of the response to stakeholders' engagement, the surveys, the events, and the responses. I think the whole thing came together very well. I think it's been an incredibly important piece of work, particularly with regard to the sensitivity of the topic. I think the financial implications, I think it would be useful to have sort of what the model cost before, what the model costs on the new model.
We can recirculate that, Paul.
Yeah. I don't recall seeing it, but I'm sure that it's all there, etc. Because I would have thought if you got something which is on a variety of sites and then you consolidate it, there must be some sort of costs that maybe you reinvest in the cost.
Time equivalent midwives, as I say, and they've been reinvested into community services to improve other parts of the service. Because as you know, there are staffing issues on some of our other units, and that by reinvesting in the community, we're able to provide more proactive support and discharge in the home. I should say a massive thank you to Hannah's team who have helped Jane with the public engagement and been absolutely fantastic.
Yeah, I think it's been an excellent example of sort of going out and finding people's comments and getting the feedback. And I think the important thing is the auditing of the responses. And I think that the outcome of the consultation has been a very positive one. And thanks to all involved.
Thank you. Hannah?
Yeah, thanks, Jenny. I just think we should note, so I know Linda's not here, but this is a really good example of really close working with FLICE as well.
Yes.
And the strong, the pragmatic, clearly patient mothers' interests at heart, but we work really closely and effectively with FLICE through this process. So
Yeah.
I know they're not here, but in their absence, I do thank them as well.
Thank you. And I think in their absence, just to confirm that they are content. Thank you. Jenny.
So can I just make the point? It's coming back to the finance point, really, and I'm sure we have had the finance information earlier on in the process. But I think when we're coming to decide something like this, which I support, I do think we need to have the full picture. So we don't want chapter and verse, but I think a paragraph on finance in each of these reports and on outcomes. So even if there are just a few outcome measures. I mean, the point that you've made, Jenny, about you've reinvested into the community, completely understandable, but something along those lines would just complete the evidence if you base the when we're making that decision. I mean, we've had it now for me because we asked the questions, but I think it's a little bit more context of the decisions that we're going to make around those two outcomes, and obviously the finance will be helpful.
Yeah.
And not just for this case,
Not just this. It's I think that would be a sensible way forward, because it usually takes at least 3 months. Thank you. Ewan?
Yeah, I know we've had even this. The one thing about the finances, and say I know we've taken 4 headcount out of this, and I think this is a good efficiency story, and I'm not sure we're making the most of it in terms of the finances. If we have, we've looked at the service, we've made it more efficient. Part of that reason was because of patient safety, and we could reduce the temporary staff in there, etc. Are we making the most of it when we come to the finances of going, look, this is the service we had before, this is the service we've got now, we've reduced headcount by 4, that's a cost saving, we come back. Yes, we've taken that cost somewhere else. But have we then gone through the process of going, yes, we want to increase that budget somewhere else, or fill in that budget somewhere else? Although we've reduced this cost, we've increased costs somewhere else, so we haven't really banked that saving. So whether or not that should come back to board saying we want to put 4 more headcount somewhere else is another question, I think. But in terms of midwifery, I think there's a good news story here. And the other one is, obviously, right from the start, we were paying incentivized pay in this area. Are we still going to continue with that, or what was the purpose of that? What are we going to do around that?
So just to say, the move of the 4 whole-time equivalents into the community was in the previous board report. So that was something that the board were cited on at the time, because I have gone back to the previous board report. So we did talk about the service configuration and the change. In terms of the variable pay, that is a further piece of work, because this service, 4 whole-time equivalents, is not going to put us in a position where this service can be safely staffed. We have staffing gaps which are much bigger than the 4 whole-time equivalents. That's not because for any other reason than...
What is the staffing? Because we were up at about 20 missing.
Yeah.
One stage.
It's about 10 at the moment, I think. The issue we have is that there simply aren't enough midwives in the UK. All of the health boards, England, are really struggling with midwifery recruitment. We've actually had a lot of success from England. So Jane has managed to recruit from Bristol and surrounding areas. So we have seen an influx, and we have had students through streamlining, but unfortunately not in the numbers that we were hoping for. So it is something that we need to come back to. It will be part of Sarah's overarching work on specialist rates and variable pay. So it will be picked up through that work stream, Ewan, but we know it's something that we do need to come back to in terms of sustainability.
In the Royal College of Midwives report from Julie Richards, it talks about the issue of future-proofing the demographic developments. So will the model be able to, is it adaptable to be able to take on board increases in population in the future? Because the current model, I think Julie talks about the current birth rate is reducing, it may be cost of living, etc. Just wanted to ask you that.
So
number stuff.
if you remember, we commissioned an external review
right.
By a very senior and experienced midwife who had worked elsewhere in Wales. One of the recommendations she made, which did come to board, but I can circulate that again, was that almost we've got a step process. I think this move is step 1.
Right.
I think there's a broader piece of work we need to do with the maternity services in terms of understanding what the future-proof model does look like. That'll be part of our normal planning processes. And we know that, for instance, we have the Maternity Neonatal Safety Collaborative that's been launched by Welsh Government. We need to take that into consideration in terms of the recommendations. So I think, well, this is step 1. There's a broader piece of work to be done that we know needs to be done and commissioned for the future.
Okay. Thank you.
Yeah, and I can link to that point. I think the question you've already asked around the finances, Paula, and sort of the same from you, and that whilst we've looked at this particular change. There is a much broader shift in terms of some of our maternity services. I think I've referenced at board before the doubling of our gestational diabetes rate, C-section rates pre-COVID being 26%, now at 40%. So there is an absolute requirement for us to look at whole service delivery, need requirement, including the prevention element of it. I know Tracy's really keen to do that for us, so that we are clear about what our strategy is and how we resource that appropriately. So things like community placement of midwives to support some of those patients with gestational diabetes, for example, is really, really important. So it is a much broader piece than just the change, which was initiated initially off the back of a safety issue, an immediate sort of safety issue. So, and it references, I think, the point that Nick almost made at the start from a chief exec briefing perspective about understanding the context we're working in at the moment, and then having appropriate service sort of set up and delivery and resources to be able to respond to that need.
Yeah. Thank you.
Ewan?
Yeah, I guess it's coming back to Shelley and Leanne's point, and that's where I think it would be important to us to know that, like, this is what we originally budgeted for. And I think in one of the papers we're down 10% on births anyway. So this is what we started with. All things being equal, we would go down to that, but we need to hold these headers because of other issues that are coming in, so that we have that view.
Just to be really clear, Ewan, there are national standards around staffing for maternity services. So we also do need to take those into account.
Exactly, and that's the view.
And there is a piece of work to do through the prompt assessment and Birthright Plus around re-looking at our staffing. But we are currently, with current recruitment, below where we should be.
Yeah, and that's a piece we'd speak on, I guess, in terms of the
and that's obviously where the work we've taken through PQSOC, but obviously can brief more widely.
Yeah, and the final one is the outcomes. You say that's been to PQSOC, and I assume we haven't seen it here, but it's that everybody is happy with the outcome. Obviously, there've been a number of maternity cases.
Work to do. And I think it's fair to say the particular concern was around stillbirth rates. There'd been because the numbers are so small, a small fluctuation in data can skew the ratios. So we've taken a report through that comes through the Embrace, which is a UK-wide assessment of maternity and neonatal deaths, and we've taken a report through PQSOC, but we know it's something we need to keep watching brief on. Actually, the data is 3 years old, so you're looking at a period of time that's so it's 1920. So our data for last year looks like we're in an improved position, but we do know there are areas we do need to focus on, and that's why it's important that we have the oversight of PQSOC with some measures and data coming through the QOF, the Quality Outcomes Framework. So my expectation is that by the time we get to the November board, you will see a Quality Outcomes Framework which has some of the maternity indicators in.
Because obviously our concern would be that we change this process and things have gotten, they haven't gotten worse, kind of thing, so that we're comfortable in putting this through.
Okay. Are there any further comments or questions? Are we content to note the outcome of the public engagement and approve implementation? And perhaps we can have a report back in 6 months about the changed indices, if there are any at the time, so that we can evaluate effectiveness. Thank you. Okay. Item 4.1, Welsh Language Annual Report. Sarah.
Thank you, Chair. The paper set out is our annual obligation to provide a report in line with the Welsh language standards, support the work that's been undertaken by the organisation from 2022 to 2023 in relation to Welsh Language Act. The report outlines a number of indicators, and again this year we've taken the approach of having a specific account of the work we've done internally, as well as the work we've done with our communities in terms of supporting the Welsh language and our obligation to provide an active offer to our population and patients that need it. Just to highlight some key positive areas of progress over the reporting period, we've been able to employ an internal translator, which has supported us to increase the number of words translated into Welsh by 27%, and to make sure that we do so at a lower cost as we're able to provide that service internally, as well as outsourcing some of that need. We've had a 10% increase in compliance of staff recording their Welsh language competencies, and that's been supported by proactive measures by our Welsh language unit in terms of roadshows and other engagements with staff across our teams and sites. We've had a healthy response to the More Than Just Words e-learning module, which currently is at 63% compliance following its first year and growing. And I'm really pleased to be able to outline in the report the proactive work that the Welsh Language Unit have done with services to support the Welsh language offer. And in the report, you'll note there's some work undertaken by older adult psychology and also our biochemistry teams in terms of work with schools and students. And there's still much work to do in terms of compliance with the 121 standards that we need to comply with. And we continue to work hard on that in terms of engagement with internal teams, engagement externally with local authority, partners through the Gwent Workforce Board, and engagement with our local communities. We do need to do more work in terms of recruitment, advertising. You'll notice a slight improvement with a number of posts advertised with Welsh Essential, more of an improvement with Welsh Desirable contained within the report. But that is, I think, one of our key risks, and we're working hard with services and colleagues to increase that compliance. We will have funding later this year to appoint a Welsh language tutor, which will support internal staff in terms of skills and confidence. Confidence we identify as one of the key issues. And we are also re-reviewing our Welsh language strategic group for the terms of reference and the membership to reinvigorate the work moving forward. So that's just a summary of some of the key points. Happy to take any comments and questions, but ultimately asking boards to approve the report for publication, which of course will be by then.
Thank you, Sarah. Good progress being made. Are there any comments or questions on this? Go on.
Got a lot to do. Must be a big cost attached to this. That it's impacting other budgets that we've got, or we got specific funding just for this.
So we have a funded Welsh language unit, which is within the Workforce and OD team, who lead the majority of the work. There's also a small budget for translation, but we've made internal changes to our team to employ that translator.
That'll be reduced, there's still a cost to it.
Yeah, so we're just monitoring those costs, and the team are always looking at ways to reduce those costs. So this year we've entered into new arrangements to reduce the cost per word, which I can share those details. I don't have them to hand, but we're working on that. There is the ongoing cost in terms of documentation and bilingual letters that go out to patients in particular. And as part of our ongoing work, we are looking to see if there's a way that we can identify patient choice in terms of Welsh or English language correspondence to try and reduce the translation burden. And that's part of our work for this year moving forward.
And do we have to send everything bilingually to everybody, or can we take patient choice?
If we are able to identify and know patient choice, we can send it in one language. But the tricky part is identifying that and making sure that we keep it consistent to our systems.
I think it's excellent, and thanks to all the staff. I mean, it's obviously it has to be an important part. I noticed the participation by the Welsh Language Strategic Group, the input thing. What can be done to try and improve that part of the group to make sure that people are attending, or is it a different model to look at or something?
I think we've got some regular attenders, and I think they're in our right areas. So focusing on correspondence, focusing on our telephony and booking services, so the first point of contact for patients. And we've also got some MPs attending through clinical services as well. I just think there's a requirement to make sure that we broaden the scope of the group, so that we can make sure that we're connecting with as many services as possible across the organisation, and also looking at our key risks and opportunities.
Okay, thank you.
Thank you.
Yeah, just a couple of comments from me. So next year we'll be launching our new patient communications platform for text reminders and digital letters. So that'll be storing patient preferences in the system. So if a patient wants to be communicated with in Welsh, the system then will recognise that and automatically send that correspondence in their chosen language. So I'll be speaking to Gainright in the Welsh language unit about that. And also there's new tools being released recently by Microsoft, which enables really good Welsh translation automatically. So if you have a Word document, you can automatically translate it. It's really key to look at what the accuracy is like in those tools to potentially use those.
We are using some of those tools now, and the accuracy is reported as very positive. So that has supported us in terms of our translation as well. And all our support is very much welcomed, Paul.
Thank you, Paul. Any further questions?
Well done.
Can we note the improvements and the progress that we've made and approve the Welsh Language Standard report?
Yeah.
Yep. Thank you. Communications and engagement strategy. What we can.
Yes, if I just very briefly introduce this work with Karen and Deputy Director of Comms sitting next to me. It committed last meeting, I think when we did the quarterly of the last report, to that we were going to refresh the communication engagement strategy. Both of them, the previously were done separate, had both expired. So Karen and her team have worked exceptionally hard to pull together a refreshed communication and engagement strategy, which doesn't just encompass our public communication and engagement, but also our staff as well, which is something we're working on. So I'm going to hand over to Karen to just take us through the key headlines of the report.
Thanks, Nicola. And as Nicola just said, I'm delighted to be here today to present our new combined strategy, which is the first one we've had as an organisation. Previously, we had communications and then separately engagement. But during COVID, we took the opportunity to merge the two functions, which I think has worked incredibly well, particularly when you talked earlier about some of the service change and some of the things we're having to do to have the two functions together has worked exceptionally well. To note, though, that obviously formal consultation and engagement still sits in planning. That has been reflected in this report as well, the strategy, about how we will take that forward. So this strategy really has been developed based on the key learnings from the former strategies, and we've also taken the opportunity to benchmark this strategy with others across NHS England and Wales, and I also asked an external colleague to do a peer review. We've worked closely with our staff to this, a Chief Officer of Llais, Paul Deneen, our independent member, who is the lead for communications, and some of our external stakeholders. And we've also shared with our trade union colleagues, and I'm pleased to report everybody's feedback has been positive and their input very much welcome to this. I'm also pleased to say that yesterday we had the support and approval of the EQIA group, because that went yesterday, who were very happy, I think it's fair to say, Louise, with the agreement that we go back on a 6-monthly basis to present this back on how we've delivered and what we've done, because this actually should be a working and live strategy as well of where we move forward with this. So I won't go through it in detail because obviously you have it there, so I'll just pick a couple of things out. We have set 7 aims that have been framed around the organisational IMTP to make sure that our comms and engagement actually support that and help the organisation deliver it, and actually trying to get the public to understand where we are going as an organisation and how we are changing and what our services are going to be like for the future. It recognises that the landscape of communications and engagement is constantly changing. It literally changes by the month, by the minute, on the different platforms and the way we can do it. And it outlines how we will listen to our staff, patients and our communities and gather insight to future-proof and guide our work and that work of the organisation as well, and how we feed that back in. It's important we do not leave anyone behind as well, because I think, you know, we talk about digital inclusion, but we also got to talk about digital exclusion and those individuals in our communities, but also within our own staff that don't have access to IT, and how we make sure we include those along the way. And I think it's very clear to say it's not just about communications, it's engagement as well, because it is meant to be two-way. This strategy also ensures as an organisation we are making communication decisions driven by insight from across what we're picking up on, and through our engagement function as well, because obviously as a team we're out in the community every day of the week listening to what the community is saying and bringing that insight back into the form then how we communicate and how we do that. But equally as important, you know, this strategy recognises how we're going to look at staff comms and engagement. And as a priority of this, we've drafted a separate strategy and plan that we are working through at the moment that will complement this to make sure that we have our internal comms absolutely where we need it to be. So the strategy sets out the frameworks, methodologies and principles that we work with. And that for me is how we support our staff to do that as well, because this isn't just about a function within the health board. Communication and engagement is everybody's responsibility and everybody's role. So how do we help staff to bring that through, and how do we help them, you know, for that to be a two-way thing? Obviously, we've included our approach to formal consultation and engagement, and I think that's never been more pertinent than as we go through now the next year or so, when we may be doing a lot more service change, and how we make sure that what we do with our communities and our staff is absolutely, you know, sort of to a standard that we would expect it to be, and that makes sure that we don't ever end up in judicial review for any of the things that we do, because we've got our processes right, and we're actually not doing it for that, we're doing it for the right reasons, and that is to listen and to engage and bring the population with us. I'm pleased to say there are no financial implications to the strategy, as if we deliver with the staffing we have and the resources we have. And I think just to sort of round off finally is to say I'm delighted that we have now actually got to the stage of having this document. I think we as a health board do communications and engagement well, and I know we brought our annual report to this the July board, but this is about how do we keep doing it better? How do we keep future-proofing the game? Because quite clearly things change and we need to be that front leader. I don't want us to settle for being anything less than the best on the way we do communications and engagement. And I think finally for me it's a massive thank you to my team who pulled this together and have worked really hard, and to Hannah's team who have made their contribution as well from that part. I'll stop there, if that's okay.
Thank you very much, Karen. That was very, very helpful, and thank you for such a good report, showing the way forward for us all. Any comments or questions? Shelley?
Could I just, first of all, it's great. Thank you very much for this, Karen, and I fully support it. One thing I wondered whether or not it's something that would also benefit if we were able to have, as part of your monitoring report, almost like case studies of where you've gone out to age in the various, actually how a service change, for example, has occurred because of the work that your team, and not just your team, I appreciate, but so I'm putting a bit more, again, context to the outcome, you know, so I'm going to say maternity, but we know you were involved in that, but, you know, case studies around just one or two things, not now, I mean, this is just build that into your monitoring process so we can see where the work is actually helping support change throughout the organisation. I think that. I don't know how you quite do that, but we can look at that idea.
Yeah, that's a good idea.
Thank you. It's a good idea.
Thank you. Ellen?
Thanks very much. I mean, mine was on a similar lines really. Is how do you know that you're actually being effective and getting the message across to people? Across, as you say, a huge organisation and so many different levels of staffing. How do you ensure that actually happens?
And that's one of our biggest challenges. But we are certainly rising to, and we're working very closely with Sarah's team, obviously, in workforce, about how we go out there and do some of this, because this isn't just about how we throw messages out into the organisation, it's about how we go and engage with the staff and talk to them and ask about, you know, what we do and how we do it. And I think that would be where the metrics and the evaluation comes in then, how we respond and report back. Externally, it's slightly easy in a lot of ways because you've got the metrics that come from social media, but also some of the feedback we get from our communities. But I think that's part of what we want to do. This is spend a lot more time looking at where things are landing, what works, and be sort of mindful about how we change them if we need to.
Thanks very much. It's a huge amount of work goes on when you look back that it's only a few years ago we had none of these methods of communicating, and most of us lived in a silo in other organisations, had no idea what was going on and no way of finding out either. So thank you very much.
I just say I think it's an incredibly impressive piece of work, and I think the decision to make a communication engagement was the right decision. I think that looking through the work about the crucial bit about being joined up really with all the community. I think if you look at that, if you put a mind map up of all the different people that need to be consulted, I think that it is incredibly joined up with regard to that. And I think that it's been a pleasure being involved as the independent member linking into communications and engagement. And it is an outstanding teamwork, and particular thanks to Karen for her leadership.
Thank you, Paul. Any further comments? Yes, Rob.
Yeah, just to really what's been said, really, in terms of our future direction of travel now, not to preempt future strategy, but the pace and changes we're going to potentially have to take forward over the next few years, communication, engagement, and getting that ownership, and actually enabling us to comply with our legal requirements, absolutely essential. So, really important piece this for us.
Yeah, absolutely agree. Fine. Okay, so we adopt the report, and thank you very much, Karen, to you and your team for your hard work in this area and the improvements. Osprey, right.
Thanks, Chair. Perhaps I have that candidate case study, problems in engagement in this next sort of item. So, as has been already alluded to in both the Chair and Chief Executive update, I've got an update for you today on RAC. I'll say for the interest of clarity. So that stands for Reinforced Autoclaved Aerated Concrete, which we've become to know as RAC over recent months. So the purpose of this paper is to update the board on our position with respect to RAC prevalence in our estate, the outcome of the surveys that we've undertaken, and to provide assurance as to how any immediate risks issues have been mitigated, but also to confirm the approach we're taking to provide a more medium and longer term solution to the situation we find ourselves in. At the outset, I should say that both my team and Leanne's team, through Jamie Marchand, have been working really closely on this. So it's a bit of a double act, but also in addition, we are working really closely with our Welsh Government colleagues in the Health Department, but also the shared services, estates and facilities expertise and professional leadership. So we are walking sort of hand in glove with them. And just to give you assurance, as well as you'll know from previous board briefings, we've been on this journey around RAC for some months now. So we are it's not just an immediate response to any sort of recent media coverage. This has been a process we've been going through some months, as you can see from the timelines in the paper. So where are we? The work we did in terms of an initial desktop review identified that we have RAC in the Neville Hall site in terms of our estate, so confined to that site. That then led us to do the much more detailed survey work on that site, working with our appointed structural engineers, Mott MacDonald. They have surveyed over the March to July months the whole site, and for those who like the numbers, out of just over or just under 53,500 square metres of estate, we have RAC in just under 14,500 square metres, and that equates to about 7,500 planks of RAC. You'll see from the appendix, and for those of you who know Neville Hall site, where this is on the site. So the two we call the tower blocks, the two H blocks where our wards are, they are free from RAC, but essentially all the other areas, single story, have RAC present. We have, with our expert professional advisors, Mott MacDonald, surveyed every plank of RAC the 7,500 planks, and in line with the extant guidance from the professional bodies, they have all been categorised into the categories you'll see in the paper. Just under 5% of those planks of RAC are categorised, as high critical, and in those areas we have gone in and made immediate actions in terms of propping. So think of it like internal scaffolding or planking, where we've put additional support into the roofs. You'll see from the paper we haven't had to displace many services, so we are unlike some other health boards in that respect, but we have had to make some not insignificant remediations and mitigations in areas. And initially propping is the first sort of line of defence, and then to planking, and we undertook planking in our kitchen, and just to make sure we can support our staff working in those environments. Hopefully it goes without saying that throughout all of this, working with our teams, Welsh Government Shared Services and our professional advisors, the safety of patients, visitors and our staff is the absolute forefront of all the decisions that we are taking. So in terms of how our approach, you'll see from the paper, we've bundled it into three main areas. And the first is this phase we're in now of assessment of risk and mitigation of immediate risk. And you'll see from the paper the actions we're taking to continually check and reassure ourselves in terms of the integrity of the planks and of the props. Alongside that, we have started sort of in anger the detailed work we now need to do to essentially move out of areas with RAC. An option would be for us to generate a plan that moves us through all those RAC areas, making good. Now, there's a number of reasons why we do not feel that that's the appropriate approach. Significant amount of cost, and also not taking the opportunity to think about how we deliver services in what would still be old estate, but RAC. So we have, as I said, started in anger the work service by service to baseline the activity, the people, the areas for each service that is in a RAC affected area, to over the next few months develop plans that will see us move out of RAC affected areas into those areas where we do not have RAC. That will involve, as we move through this phase, which is the phase 2, which they are operating in parallel, that will involve inevitably some redesign, some consideration of services, what the opportunities are to potentially do things in a different way. And obviously, as and when that happens and we've got the plan, we'll bring back to the board. A final comment before I bring Leanne in, if there's anything else she wants to add, is that we've just come off the back of the item around comms and engagement. It's mentioned in the paper, but it, on reflection, could have been strengthened. We are taking we're trying to take a really proactive approach to comms and engagement. Karen sits on that one of the groups that meets frequently to sort through the immediate issues, and also that interface with the group I chair, that's the more medium-term plan. We've been to the Trade Union Partnership Forum. We've spoken to Cleiss, we've spoken to Linda, we've spoken to colleagues from other health boards to brief them on the position and also seek their support to engage with us as we move through the more detailed service planning areas. There's probably always more we can do in this space, so I think we have to continually sort of hold the mirror up to make sure we are communicating as effectively as we can be. So I'll just, before we open to questions, hand over to Leanne in case there's anything you wanted to add that I've missed off.
I think just to reinforce, sort of, we take the safety aspect of this sort of incredibly seriously for our public, for our staff, and I know there'll be a lot of press from sort of other hospitals in Wales. I think fair to say that maybe sort of causing angst with people, but I'm assured with the processes that we have in place that we have taken sort of the approach that the site absolutely has to be safe, and that has been sort of the approach that we have taken. It is really important that Hannah and I continue to work sort of very closely together, and with Peter's team from a health and safety sort of perspective as well, with those assessments. I think probably the other thing outside of the RAC thing that we have picked up is additional issues, I guess, with the infrastructure from a building perspective. It's not just RAC. when we've undertaken sort of the surveys that mean investment in
been consuming resources in terms of the actions. I don't want, it's really important. Resources haven't limited our approach to putting safety first in terms of the appointment of the engineers, the actions we've taken. We have very clear indication from Welsh Government that they recognise that and will support. And they are obviously keen to work with us then on what the more medium term and then longer term solution will be. So it's very positive in that regard. It's important to note, I think Jamie can say it, who's here, so we are in a different position to another health board who's finding particular RAC challenges. Happy to take any questions as long as I'm not too technical. Okay. Paul.
Can I just say, I've been incredibly impressed with the fact that we seem to be ahead of the game on with regard to the RAC, because suddenly it became a massive issue, I think, nationally. But we seem to be in a very good place with regard to where we are. And I think taking that on board, I think there is an opportunity to reflect, rethink, remodel, redesign. If we have got resources that may become available, then it's opportune to think about, okay, well, how will this fit into the mid-term, longer term strategy, rather than simply rebuilding what was there before. So I think it's but having those conversations and consultation engagement may well be part of that. But do we know what's going to be happening? What about the actual cost in terms of insurance or anything? What's the...
Well, we've spent, as we're incurring costs at the moment, and as the paper outlines, we've already incurred around £250 million in terms of the actions we've taken. We have got some indicative costs, but they're high level in terms of what it would take to sort of some of the actions to remediate further. But for the reasons for the reasons we've said, and I alluded to as well, we want to make sure that we have a plan that goes towards a solution that's going to endure really, and not just, we'll make some of the lessons learned from maybe in other organisations. We're not just going to take the approach of in every area replace like for like. So we don't have the costs yet because we haven't finalised a number of areas of the plan. So there'll be costs that we'll be able to look to Welsh Government for those we've incurred that which we've incurred this year. And then they'll continue to work with us on what we require first.
As we have invested in Neville Hall with particular sort of areas of activity.
Yeah.
Of course, that may be something we can explore in terms of developing that, as opposed to just replacing what was there before.
Absolutely. And I think it's really important that we just restate our commitment to the Neville Hall site and its future, not least, we're developing a beautiful new satellite radiotherapy centre there. And there's opportunities, in terms of the facilities that we've already got there. So the commitment is there, but what and how it's configured, with RAC being sort of the thing that's really focusing our attention to do that in a proper way, but in a maybe with a much more sort of pace behind it than maybe we would have if we hadn't have had.
Yeah, sorry, just one other thing to flag. So the areas that we do have RAC in are pretty technical areas. It's important to flag: pharmacy, pathology, radiology. So they are kit or equipment heavy. I think that will present some logistical challenges for us in terms of either repair or even sort of a shift. And they are pretty fundamental to service delivery. We had an incident with the pharmacy at Neville Hall recently, so that we had a fault with it for a period of time. It causes quite significant operational issues for us. So that operational interface in terms of sort of the planning around remediation or even moves, I think will be critical to make sure that our services remain sort of safe and sustainable. I think it's just important to tease out that those areas are pretty challenging for us, really.
Yes. Thank you. Any further questions? I mean, this is a very complex issue. think we have to note that a huge amount of effort has gone into making sure, from every point of view, and that will continue. I know Jamie himself is sort of bringing in extra individuals to ensure that the health and safety checks are very, very regular, because we can't afford to do anything else, and that we have a commitment to provide a really high quality service and fairly for the population. And it's on that system. Okay. Thank you. Okay. Thanks very much. And thanks to the staff. Okay, I've been continuing to work in really quite testing environment. Really quite testing. I know you've taken you've taken extra precautions in some departments where it was very difficult.
And just on that, we were with Louise in the Trojan Partnership Forum for the week, and and over through Jamie's team particularly, it's a very open honest on where we are, but keen if there's anything more we can do. If we need to more comms than that coming through, we'll make sure we respond.
Lovely. Thank you. We can pass on to page 4, the annual plan. Please, Hannah.
Thank you. This paper is just a brief, really, overview of the approach we're taking as we think about next year's annual plan, which I guess at the outset to say that we are going to be focusing on an annual plan rather than based on the context we're in, the challenges we've spoken about in terms of the financial outlook. It is, as we said, it is going to be challenging the year ahead. So our approach for next year, whilst we're not losing track of delivering this year's plan, our approach for next year is going to really sort of unapologetically focus on quality and safety of our services, but whilst looking at that through a value lens, a value from the resources we've got. The paper sets out some of the milestones with an end point of a plan coming to the board in March, but with hopefully we'll see a number of points throughout that process where we get the engagement with yourselves as well as in the organisation. Some key features of the approach we're trying to strengthen going forward into this year, recognising the context, are that as I said, it will be really focusing on annual plan. But we will be looking at actions that will lead us towards sustainability, and part of that being the actions that we want to take and the commitments around developing a longer term strategy. So we will be seeking to still pursue that next year. We are going to be really upfront with the organisation this year through the issuing of planning parameters and planning assumptions around the context, around those parameters within which services can plan. So financial, what are the financial parameters, will workforce, operational delivery, etc. So the development of those is sort of very current at the moment, with teams I know met yesterday to flesh some of those out, and we'll have a session as execs next week to test those. But that's a really important element to the approach for this year, so that we are really clear on our expectations, but really clear with the organisation too around that context. Another key feature is we're going to strengthen the integrated nature of the plan. It's obviously an integrated IMTP, but myself, Rob, Sarah, commitment to making sure that we do the operational planning, the financial and workforce planning sort of together and keep that tightly woven and iterated. And we're going to be ambitious but realistic about what we can deliver in terms of the ministerial priorities or targets. So really using productivity and efficiency to understand where those opportunities are. So again, that will be part of the message out to the organisation in terms of expectations and assumptions against which to plan. So I wasn't going to say much more on that in terms of timescales, and we're at the sort of the start of the process, but we are committed to getting it right at the start to avoid abortive work, because colleagues are under lots of pressure and have many competing demands, but also make sure that it's an approach that we engage. We talked about engagement a lot today, and it's an approach where we iterate and it picks up all the elements in terms of finance, delivery and workforce, with that focus on quality. So that's all I was going to say on this paper, Chair.
Thank you. Thank you, Hannah. Any questions? Phil?
Yeah, it's good to see the document. I think in many respects it's very strong in terms of ambition, but in some ways I think it's a bit old hat. it doesn't reflect the ethos of a modern public service, very single agency. And I wonder whether now what we should be looking at to take it to another level would be looking at more or at some agreement around Gwent-wide priorities. I mean, it would be many of the milestones, for example, we can't accomplish on our own anyway. I mean, it would be tremendous if the whole Gwent kind of public service could have sustainability of primary care, for example, as an objective, wouldn't it? Or workforce issues. I mean, it's written as if it's just written about the health board. And I think a modern public service now is not just about one agency. If you read the stuff they do in Greater Manchester, for example, there's great synergy right across the public sector there. You can see them all signed up to 8 or 10 major priorities that they're all actually trying to deliver. And I think what you get then is if you get signed up at the senior levels of these priorities, you don't have to get down in the gutter and fight between agencies then, do you? Like we have to at the minute. You know, some of our experiences that we have to fight with every day, you wouldn't have if at senior levels there was a Gwent sign up to 5 or 6 major priorities. So I think that's where it's weak. It's strong in many other areas, but I think if we could look at that, then I think we'd have a plan at a different level.
I agree with you, and I think we've had some recent time when we think about the strategy and understanding our role as the health board, but then where we fit into the whole partnership arena. And I think there's been some quite helpful discussions recently with local authority chief executives, police, in terms of what are the big things that we need to do together if we're really going to make a difference to the population going forward, and use the Marmot region kind of launch now as part of the Public Service Board. And almost let's forget the names of the Public Service Board, the RPB, the Health Board, and the, you know, as partners for this region, what are we going to do that's going to make a difference? And then how do we use those different forums to help us deliver that? So I think that's what we need to do, and I think we need to use Marmot to do that bigger conversation, the bigger priorities. And then I think it is easier for us to link our annual plan or our INTP into that wider piece, because we also got an area plan. So there's a whole raft of planning. And a lot of that is kind of an expectation through the statutory requirements. But I think you're right, we need to start at that Public Service Board level with the project. And then I think it's much easier. You know, there's possibly even a need for us to strengthen through next year's plan how all that comes together. So we can show where our plan sits in that regional landscape. But I think it's some of those others that we should bring back to the board as a key partner to say, what are the big things we're going to do together that makes a real difference across. So you said a lot of this we can't do. We do some bits on our own, but a lot of that is the reactive stuff that we do. So I think there's been some really, I think, optimistic conversations. It's about where we go with the next.
That's ideal.
Yeah, I don't disagree with what you said in terms of where we should and where we want to be. So just, endorse everything you and Nicola said, and we can update this to reflect that. That's why it's good to have these conversations at the start of the process. And you'll know from the RPB conversations, we want to have that session to look at our priorities as an RPB, as a partnership. I think is what Nicola was saying about the Marmot stuff. So that's really helpful feedback that we'll strengthen in our approach.
I mean, I think we can almost take it with what Nicola said above the RPB. The chief execs meeting and Anne's meeting the leaders, for example, of councils. I think that's where the real work needs to take place now. And then the RPB almost be told, well, this is what we want you to do.
Not quite.
Not
quite. No. Well, we certainly, Nicola and I have raised this at the PFB, and I have been talking to the leaders about, we really must be clear about our priorities and how we drive the Marmot principles through and what we're actually going to seek to achieve within the next 3 years. And that's the conversation at the next PSB.
It would be great if we could have something like, dare I say, the new Labour pledge card, wasn't it, really? The 6 pledges, and we'd say, well, these are the Gwent pledges. We're all signed up to it. This is what we're going to do. I know, I'm not saying any of this is an easy one. I know.
No, it's not. But we've got to have a go at it. Rob and then Shelley.
Yeah, just to follow on really what Hannah's picked up around setting the parameters and the ambition, I think, in terms of expectations for the overall sort of health board. What are we going to do next year as part of the wider longer term plan. Obvious thing for me to pick up in terms of how that sort of fits with the limiting factor of the finances.
Yeah.
You know, the rub of the finance versus service delivery as well. And that's something that the board will obviously need to consider as we iteratively work through it. We haven't really touched on execs yet, but we probably need to have a clarity on what we think of our sort of start point parameters. So, for example, we could say assume the same level of funding, which would be a you know, quite a simple mechanism to avoid confusion. And also part of the work that Anna's outlined in this, which is really important actually, to look at capacity, our core capacity and what we can deliver, because there is an element of what's our ask on the service, rather than presuming that, you know, everything can be done, because we can't afford to do everything.
I agree with that. Thank you. Shelley?
My only concern about sort of the annual approach is that we can try and do an annual approach, but we really ought to still be looking at the 3 year. I understand the position we're in because of the way that it's set up. Because I would be happier if, I mean, I understand you've got to do this, but actually, where does this sit within that 3 year, 5 year, and 10 year potentially? And I appreciate that's where you're working. But again, I think when you're looking at this, I'd be concerned about we're looking at this on a 1 year basis, where a lot of the things that you're suggesting in terms of the areas aren't, I mean, you know, primary care sustainability absolutely needs to be in there, but that is going to take some time to actually work out where we need. So I know you're probably doing it, but I'm just saying to our paper, not so difficult. You know, when you present again, I would like to know where this sits within, you know, and I think again, it's about having those actions. This is what we're going to do next year. But actually, that's the first stepping stone to the second year and what we are anticipating doing in 3 years.
Yeah,
Does that make sense?
It does, and agree. And it's probably the language, isn't it, in terms of annual plan, IMTP, which is the 3 years, and the expectations that go with calling it an IMTP, that it's balanced and everything, recognising the challenging position we're in. But absolutely, the work we're doing, and hopefully you can see that we're doing. So the actions and some of the work we're taking forward, that you would have seen from the outcomes of the clinical advisory board, they've got a longer time frame than a year. I think, and it's again, we need to find a way to describe it like an annual plan in a 3 year context. Because a lot, as you said, a lot of the things we'll be doing will have a longer horizon. And within next year, as we sort of talked about in the development session, we want to develop a strategy. So I wouldn't want anybody to think that we're just focusing on things that get us through the year. That we will be committing though to do things within the year that take us sort of into our future, but defining our future. And for some services, we won't see some of the benefits of all the things we're starting next year until future years. So I accept the challenge about how we present it.
And just follow up just on. So I think what I think is important is that when you do present like the annual plan, we know what we're measuring ourselves against for that particular first year in the context of the 3 years. So it has something tangible. Yeah. Because otherwise we could be in a position whereby we can't actually pin down next year what we should have achieved. I mean, I know it's tricky, but I do think we need to plan.
Yeah, some parts of the plan we'll be able to have some granularity in future years. For example, you know, the capital plan will take us into future years. So, accept that.
Paul, and then you.
Well, I think the Armut sort of situation, I think, is something which is exciting and we need to work on and develop. That's important. But I think Phil's point about keeping things simple and having sort of 5 or 6 or whatever pledges, I think is something which is important. And on the context of maximising the use of resources, because we are going to be in a situation where resources are going to be declining, and therefore the best thing to do is, if combined resources are something we can work together on, and using all the people within Gwent to get the best use of the resources available to the community to best effect. And I think what's also useful, we've got milestones, but what would be the millstones? What are things going to stop us to do anything? What would be the sort of, how can we perhaps use those as part of the conversation about maximising the resources to say, otherwise, we'd like to develop this if we're all working together. Otherwise, just some thoughts really.
Yeah.
But we do also have to cover in this plan the ministerial priorities, not just, you know, the sort of longer term vision.
Yeah, we still have a unknown study. We don't know what the outturn this year is going to be. We don't know what the sort of settlement for next year, what the planning framework will be, what the ministerial priorities. So the very nature of planning, we will have to be reviewing, you know, our assumptions as we get more and more uncertainty.
Ewan?
Yeah. To be honest with you, I think the risks have been covered, you know, bringing the risks into the plan. But obviously, part of that 3-year planning, we committed as a board. Yes, we wouldn't be in balance this year, but we'd bring us back in within 3. I think we have to demonstrate that as part of this plan as well.
Yes, absolutely. Yes. Any further comments? Okay then. We're happy to note your work. Thank you. I know you'll take the observations on board.
Really helpful.
And we'll take it forward. Lovely, thank you. It's your show today. The integrated performance report.
Don't worry, I'm going to be phoning a friend about this. Thank you, Chair. So you have the performance report in front of you, which is sort of a mini version of the quarterly report that colleagues will be used to. This updates on some of the main reportable targets and standards, including ministerial priorities, and with data up to August 23. So there's some information in there you'll know through both, we've talked about performance management framework. As part of that, we're looking at this, as well as feedback from the internal audit review we had on how we track delivery of the IMTP. I just wanted to pick out some positives from the report, where we're doing well, and then also pick up some of the challenged areas, and we'll hand over to Leanne to give a bit more assurance or in some of those challenged areas. So in terms of some of the positives, hope you can see from the report. So our waiting times for paediatric surgical services, we've done a really concerted effort to get rid of the long waiters. We are not happy with 2 years waiting for our paediatric population, but we are bringing down sort of the tail end of those long waiters, and we've made good progress. And whilst, as I said, we're still not resting on our laurels, we are sort of leading the way in Wales on this, but lots more to do. And we have, except for a handful of patients due to their individual choice, eliminated long waits, so for outpatient appointments. So we had patients post-COVID waiting over 3 years for an outpatient appointment. So except for single figures of due to patient choice, we've eliminated those. We've made, to the theme around productivity and efficiency, which we come back to a lot, we have made good reductions in outpatient DNAs. So the national standard is 5%. We were at 6.3% in April, and we're down to 5.7%. Again, still much more work to do, releasing huge opportunities, but going in the right direction. You'll see we've made really good progress through a sort of a combination of actions around cardiology diagnostics, and our performance against the single cancer pathway. So even in the face of a significant increase in demand into our cancer pathways, we continue to improve performance up to 60.2% in July, and early indication, the numbers don't close till the end of the month, but that improves again into August. So recognising that we've still got huge challenges in this area, but we have a new approach, a new manager, a new sort of focus on this to get from a tumour site perspective and backlog perspective, but good progress. In terms of some of the challenged areas, you'll see from the report we are off where we committed to be in terms of our delivery against the 104 weeks, so the 2 years in planned care waits. This is due to very specific issues in specialties or subspecialties. So it's limited to the areas of ENT, spines, and neurology. There is detailed work and recovery plans being updated for those specialties, a mix of demand management approaches to additional capacity, validation, clinical review. But there is a real renewed focus through Leanne and Rich and the team in looking at these to bring us back in line with our commitments. we agree it's really important that we deliver what we said we would do in terms of credibility and moving forward. So real focus on that. We'll all appreciate that our urgent and emergency care system remains really challenged. You'll see from the report the time spent in ED for our patients is increasing. And whilst we are making progress, we still have more than we would like and accept. High numbers of patients who are delayed in the back of ambulances before they're handed over. So we are making progress, as you can see, but we're all committed to through the actions outlined in the paper to improving that further. There's also going to be a big drive in terms of some of the delayed pathways of care. You will know from the communication, the work led by Leanne and Jenny around the patient safety events started today to have that real multi-professional senior leadership and sort of breaking the cycle and sprint methodology improvements there. So recognition that we have got more to do in this space. And again, you'll see from the paper and from previous conversations, we've got some challenges in our performance around mental health. We've talked many times in this room around the challenges with the system, the WICIS system. We have the system now. There remains a bit of a backlog, but the system is now telling us our performance is not where it needs to be. So we have some real focus working on that. Leanne, you want to come in on that to provide insurance?
I think mental health is sort of obviously a tale of two parts. The children's sort of mental health sort of measures as well as the adult. Just for assurance for the board, Richard and I put in place a fortnightly performance meeting direct with the services to drive forward the performance in the same way that we have done with physical health as well. So from a planned care perspective, I think it's fair to say they have sat separate, I think, sort of to the organisation in relation to that. That's as much about sort of organisational support as it is challenge as well. I think important to say we do require I think, sort of a detailed recovery plan in those areas. And I just wanted to share, I guess, some of the difficulties that we're encountering at the minute in the different services for different reasons. I think our ability to not report any figures for a significant period of time via WICIS has been really challenged for us. I think particularly in terms of the backlog catch up then and then the validation that needs to take place to ensure that that demand and the patients that we're capturing is appropriate and accurate as well. And if I reference CAMS as an example of that, about 30%, we've had a bump of about 30% increase in demand that we were expecting from our original trajectory off the back of some of the WICIS work that we're just sort of working through at the moment. I think CAMS in particular have been pretty innovative, I think, in terms of their approach and have flexed in relation to sort of the pathways. In reach workers in schools, for example, have been successful in mopping up around 40% of demand into CAMS services, which I think is absolutely right on the spot, in the place, sort of supporting our children and young people, I think, sort of in the place where they can be helped. But it would be remiss of me not to mention, I think, some concerns that have been flagged, certainly from the performance meeting this week. Pre-COVID, referrals into, say, our ND service from a children and young person perspective ran at around 50 a month. Post-COVID, it increased to about 150. And in June and July, we've seen that increase to 300 referrals a month. So given the very specialist nature of the service provision that we have for these individuals, I think we really need to go back and do a forensic sort of assessment of what that looks like, and referencing, I guess, sort of Phil's point around a multi-agency approach to how we deal with this. I think that is absolutely sort of key for us, about only ensuring, I guess, sort of those with appropriate health needs are coming into the service, but we have a whole system design that meets the needs of our population, whether they're health or sort of local authority based. So I think there is a very bespoke piece of work to be done in that area. In the adult mental health arena, I think there are some very bespoke operational issues at the moment, certainly from an assessment perspective. We've currently got 40% of our workforce off sick. which is massive, completely the rest of the organisation. I've been told that that is being managed appropriately, but I have asked for a deep dive and some support from Workforce, I think, to ensure that that is being managed appropriately, because that has a very significant impact on our sort of service delivery. I think it's also fair to say, I think we've not applied, there are no bespoke RTT rules or guidance around mental health. We've picked that up with our recent sort of conversations with Welsh Government. We've had a really helpful sort of support from Dave, who's been supporting us on the quality agenda as well, hasn't he, Jem? But he obviously has a performance lens as well. And I think we need to push back on that, because I think sort of we are not helping ourselves around this. Rules around DNA engagement, and whilst I appreciate these are mental health patients, I think those rules are still equally valid and can be applied in a need sensitive way, I think, sort of, so that the organisation is not necessarily being penalised around that. But I think just to flag, we have undertaken, and we've had some support from our planning, a business partner, around some process mapping of our services, because I think that there's quite a lot of normal organisational, I guess, rigour that and process that we can apply that will bring benefit for our patients. Application of, for example, to pull on application of doctor. We've got some quite what I would describe as maybe archaic is a bit of a stretch, but traditional models of healthcare delivery that have moved on sort of considerably. So there is a lot of work to do there. We are on it on a fortnightly basis. As I said, Rich and I have dedicated that time because of that. But I think there is a broader recovery piece that links in for sure with the quality work that we'll talk to the board about later on today. So not good enough. The services are very well aware and are committed to improving where we're at the moment. But there is a lot more work to be done in this area. Thank you. Let's take questions. Did you want to say something?
No, I said,
sorry. I just want to come in on the point around 40% sickness percent. So it's not reported on our information. So I'll very happily pick that up with you, because there may be specific teams within specific areas which are having that particular problem. So absolutely support your call for a deep dive there, and we'll be ensuring the team give more focus.
It is a very bespoke team. It's not obviously generic in mental health services, because we wouldn't be able to provide a mental health service if our sickness rate was at that level. But it is having quite a significant impact from an assessment.
Imagine,
a particular team. Yeah, no, absolutely. And I think just to flag, really important from a safety perspective, that even with those delays in assessment and that sickness, there are signposting options for patients should they require immediate help and support. We have other emergency groups as well, I think. So I think it's important to reinforce that whilst this is a performance measure, safety is paramount, and we are reinforcing that via the quality processes. James.
And added to the fitness issues, following intelligence from Jenny and Leanne's work in mental health, I've reached out to the adult psychiatry team to ask about the safety of their staff across all sites at all times, and they've given me a breakdown. We already knew that 60% of consultant staff within adult psychiatry were locums. But once I've seen the detailed breakdown, I'm actually quite concerned. We have pretty much whole services being delivered only by locum staff. And within that envelope, there are 5 consultants who together are costing us £1.25 million. And I can't help feeling that we could be spending that money differently.
Thank you, James. Please do pursue it. Because that is a huge number of people who are locums in trying to provide a critical service.
Yeah. Paul, can I ask whether we've got any information on why there's been escalation in the PAMS NDs sort of numbers for the children? Because we seem to be, that's the escalating number seems to be. Any reason or rationale? And is it just in Aneurin Bevan or other health boards?
I think there's been a generic increase in demand post-COVID, or I think it's fair to say. I've got in fact a draft paper to come to execs in particular on the children's mental health services because of the concern and worry about it. I think that the bump that we've seen in June and July, when validated, I've asked for sort of just further evidence of that, I think is a big worry, because if we've seen a trebling since pre-COVID to post-COVID and then a doubling of that number, I think that suggests that we need to respond in a very different way. It is I think it's a generic issue where it feels as though I think society is struggling to cope. We've talked about health visitors when they're going out to visit sort of to homes. Mothers are reporting a 50% sort of request for mental health support. So I think there is a different way of us looking at how we support people with mental health needs across the whole of our system. But there's an executive paper that I'm currently in discussion with the division on that will come forward that has that detail in.
Okay, thank you. Yeah.
Kelly?
Wanted to first of all say how pleased I was to see about the trusted assessor roles now being implemented across Gwent, because I know previously had difficulty in getting that sort of thing. So that was really good to see that. But also in relation to the hospital to home service, because I'm assuming this is quarter one. At that time, there were only 11 patients who had assessed the pathways. And there was, it says here, and there was a RIF application for continued funding. So I just wondered whether or not we had an update in terms of the number of patients.
I didn't have that.
Could I just say, I think the term trusted assessor is being applied to the Newport model, not to a model anywhere else in Gwent at the moment.
It says progress has been made with regard to the trusted assessor role and function, which has now been implemented across Gwent with local authorities. So
If that's inaccurate, then I apologise.
Can we just, because we get one report that says no, and another report that says yes. So it would be really, really helpful. But the Minister has picked up the whole issue of the trusted assessor, and the regional partnership boards are going to have to respond to it in 2 weeks to tell her exactly how we're doing and what the consequences are.
So I think it depends on your interpretation of progress. If we are making progress,
implemented.
I think we are implementing trusted assessor models. Some of that is around how we are reorganising our own resource, particularly in our CHC nurse assessors. But we are making progress in terms of working with each of the authorities. We'll make sure we have an accurate position of where we are, but there is still work to do. It is being implemented, but I think slowly would be what I would say. In terms of the hospital to home, we can get you the up-to-date details. We are expanding that service. The time the report was written, that we were in proof of concept stage, so we kept it very contained. It's utilising some of our in-house resource for complex care, but also looking at how we expand and develop that team. So that's about bringing people into the home environment, caring for them for a short period of time so we can do the assessment where they feel comfortable, where they know their environment, and where they are more likely to have a realistic assessment of need.
So can I ask a follow-up? So does that link in then to the work that you've got in the Integrated Discharge Board and again, patient safety team events, which Hannah's just mentioned, which again, I thought it says commence September, but obviously that's commencing today, so we haven't got any data. But that all links into that overall.
So what we've done in the Integrated Discharge Board is reprioritise what we are planning to do this year. So the hospital to home is one of those initiatives that we're prioritising, because actually the data from the initial pilot has been that it's incredibly successful in having a more realistic number of care package visits, for example. So, we are seeing a reduction in terms of need because people are in the environment where, actually they are able, they were more familiar, they're less likely to have safety issues and are more comfortable. We are also, so that we have a number of initiatives which include trusted assessor, the patient safety there's patient safety days, and also clearly the work we're doing in the RGH, as well as, which is proving successful in terms of our relationship with Newport, as well as the work we're obviously doing in working with, I think it refers to Monmouthshire as well. So we've got a pool model, slightly different model to RGH, Neville, but essentially we've come down to a smaller set of priorities which we think we can deliver.
Can I ask, does the Welsh Government, when they're reviewing our performance, take into account the increase in referrals in services? Do we know? Or isn't there?
I think it's sort of context we provide. We've got IQPD, haven't we, this Friday, where we talk about a number of these areas. So it's context we provide, but it's I don't think it's sort of seen as mitigation. I think it goes back to my point that I raised in my report is I think it, you know, the sort of examples Leanne's quoted, I had a couple this week about spinal referrals. Yeah. We've talked about diabetes. So I think pulling a report together which tries to capture what's happening to demand in a more cohesive way that enables us to have that discussion we need across the different elements of service would be quite helpful. And there could be other areas where we've seen a reduction in. But I think trying to understand what is happening in when and pulling it all together might be quite helpful to help understand the context with which we work in and which need a different approach. And to understand why then, when you just look at progress of bringing the waiting list down, none of that takes into account what's actually coming behind in terms of the cohort. And if you've seen a big increase in your cohort and others happen, then you won't see the same improvement. So I think it's really important we put some intelligence into the system, and we have done.
Good, I agree about that. And can I ask about paediatric surgery? We were concerned, and I'm glad to see that such improvements been made here in paediatric surgery waste. We were also concerned about the specialist service. Has anything happened to improve that?
So I know there are concerns of it.
So we picked up at the WISC meeting recently. They have been, whilst they're working with Cardiff on their ability to get back up to pre-COVID levels, and they've got some workforce issues, is they have been outsourcing capacity from England to help reduce those long waiters, and it's something that we're keeping under review. But there's been a plan to outsource capacity, to commission extra capacity from England to help address those long waiters. But maybe I'll get an update in terms of maybe patients.
That'd be grand. Thank you. Are there any further? Oh, yeah, Bill.
Yeah, it's interesting in general performance report. I guess you start with the children. I mean, I guess that's incredibly difficult right across the whole system now, isn't it? And I guess one of the difficulties in there is if the mental health services are not able to see, then the only doors open to parents will be either the school or GPs. And I know GPs are feeling huge pressure, aren't they? They simply don't know what to do with the tsunami of families attending because they're not equipped and set up to deal with the issue. So I know we've made some inroads in schools with housing and all of that, and it does feel to me as if there's more appetite in the children's world to look at new solutions in a joined up way than we've seen in the adult arena. And I guess that's why we're seeing some good initiatives in children's work. So I think we need to build on those. So I guess all we need to do is continue to work as hard as we are to try to deal with it. There's not much else you can do, is there?
I think there's a lot of redesign option available for us. I think there's an aspiration around the service around a single point of access for mental health services as well. Because we've got quite a disparate patchwork quilt, I always describe it. It's grown up over time, and that's not how you would start with a blank sort of piece of paper. Some of the GPs have mental health practitioners in their practices now, recognising how busy that arena is, and in fact often we get referrals in from those practitioners as well as from GPs if they see them. I think there's more that we can do there actually, but if I also think about the application of the waiting well agenda and policy from Welsh Government as well. I think there's a lot that we should be doing in the prevention sort of arena as well, which does require that multi-agency sort of approach. So as well as ensuring our teams are using their resources effectively and efficiently, I think there is a bigger piece for us around what the whole system looks like, in taking into account prevention, engaging with our communities around what they can do to help themselves as well. Because I think there is a lot that we can do in that arena.
I think huge services in government that probably are untapped at the moment in that area. I mean, youth services, for example, provide incredible services, which, if we can bring into the loop, could actually make a difference. You know, with highly skilled, work with young people who are challenging in different ways. So, I mean, I think we just need to unlock all the potential that's out there.
Yeah.
But turning to urgent care, clearly there's lots of heat still in there. I mean, that's obviously the really tough end of the business continually. I see we've got nearly 40% of people now waiting on an ambulance longer than we've said 60 minutes. 60 minutes doesn't seem that horrendous compared to some of the times we were seeing before. But I wonder just what the time is like after 60 minutes. I mean, are we seeing the, you know, the 8 and 10 hour waits that we saw before, or have we improved that?
No, we have improved the very long waits. I think it is that we've not completely eliminated them. And you know, by an example, I had a question sort of earlier in the week. There was a 30-hour wait in Morriston this week. It's a horrendous sort of patient experience piece. There's been a revised focus on some of the safety flow work, the offload of ambulances in particular. And it's also encouraging to see the team, the ED sort of new CD, we've got an interim CD there at the moment, coming forward with a proposal around rapid senior sort of assessment, that some emails sort of doing around sort of today on that will have a significant benefit. We can hold assessment couches or throughput through the department, the congestion in the department, I think, would be significantly improved. Jen has set up an improvement day facilitated by sort of an NHS England colleague on our demand management, I guess, approach with WAST on the 4th of October, because we know that there's more that we can go at in terms of from an ambulance conveyance perspective. And in addition to that, one of the things that was included in the winter plan was a mental health response car as well, that we wanted a pilot sort of for winter. So the environment is very busy with lots of activity to try and sort of hold the demand at least, as well as improve the performance and most importantly, the outcome for our patients. So too much to describe for today, but more than happy if you think it's helpful to come back and do. I think probably there's an assurance piece at the board ahead of winter. Yeah, that we're going in sort of in the best. Yeah, but so the long waits, we are committed to eradicating. I think we've made good progress, but there's more to go out there.
And thinking about winter, of course, we've got 300 delayed transfers in August, and they are now verified delayed transfer figures.
Yeah.
I'm not sure that we probably had 300 in August before, because they were unverified. When we were talking about 500, we've now got a good grip of the figures, but 300 people in our beds who shouldn't be there in August. This is quite worrying. When you think that we're 2 or 3 months away from serious weather and the rest of it. And I mean, I think we've got a short window now, haven't we, to try to really impact on that, because we've been working on it for some time, but the outcome of that yet is not really bearing the fruit, is it?
So we've got.
I'm not meaning that to be a critical comment. I'm just saying that the figures are not actually showing that we're getting hold of it.
No, I completely agree, Phil, that in spite of how hard people are working, it's demotivating for those individuals, I think, not to see that dial shift or move. So what you probably won't be sort of fully appraised on. So today is the launch of our patient safety events. We've got 2 days happening in the Gwent this week, 2 days happening in YYF next week, and then a 6-weekly cycle of targeting both the complex patients, but also the non-complex patients as well, to identify, to drive forward, I guess, sort of a move through of patients through the system so they get back to their usual place of residency as quickly as they can. It is absolutely the right thing to do. They are deconditioning in our beds. There are risk of falls, and the way we've approached it, the teams, I'm incredibly proud of the team. The number of people we've currently got in the Gwent sort of today and tomorrow, spread over the wards, forensically assessing why they're in the beds, what we can do. The multi-agency engagement we've had on it, I think, is really, really encouraging. We did almost a readiness check yesterday for the events, and my plea to them was, let's bring back the learning around how we stop this from happening on an ongoing basis. Everyone, Jen, Peter, James has done sort of the comms. We've been really well supported by James and Hannah as part of Karen's team around really pushing the message, doing this in a different way than I think we have done before, this breaking the cycle that we've done sort of historically to really get patients back to their homes as quickly as they possibly can when they are fit and ready to do so. So we'll have an update for you pretty soon. I think the next week is pretty fundamental on lots of different levels, but hugely exciting to see what that approaches will bring for us. Essential piece of work. Absolutely. So we look forward to receiving the report as soon as possible on that. Is there anything further on the performance report? Finance.
Thanks, Anne. The report is included in the papers. There is month 5 financial performance position for the year to date April to the end of August. In terms of key performance indicators, in terms of the revenue position, we reported for the period to August £71 million deficit. That's £20 million adversely above our planned profile, so obviously brings in issues in terms of how we've performed for the year to date and where we need to get to for the rest of the year and the risk potential forecast, which I'll come back to in a moment. In terms of capital, we are expecting to break even. We've had some positive news in terms of some funding there, so that's taken the risk of our capital plan. In terms of public sector payment performance, we've achieved the 95% target of non-NHS suppliers being paid within 30 days. And our cash holding is actually 6.1 million at the end of August, with a best practice target of 6 million. So we're slightly above that, but we did have an unexpected receipt very late in the month. We thought we were going to be receiving in the following week. But again, very close to the best practice target for that. In terms of the forecast, and we've discussed the forecast on several occasions, but as previously discussed, the forecast for month 5, we reported £112 million. That is a best case. And in the paper, there is a summary which identifies the risk range and how that risk range is made up and the factors which potentially run from 112 to 160 worst case. So just noting that to hold our forecast at 112, we have significant mitigations required in the second half of the year. In terms of our recovery actions, reflecting where we are currently, Value and Sustainability Board has been established. There are 6 focus areas and a 2-weekly beat with exec leads identified for each area. There's also been some immediate actions, things like a vacancy panel for administrative posts, and freezes on things like office equipment and furniture, as well as some other actions being taken forward as well. The big sort of flag for the day really is the month 6 mid-year review process will be absolutely critical to consider and assess our forecast and ambition and delivery for the rest of this year, in terms of where we are likely to achieve as a target for the year end. In terms of key points for month 5, our income assumes full pay award funding and full receipt of our anticipated income sources. So picked on before, some of the funding sources that we were advised of through allocations, where the criteria for receiving their income has become a little bit confused. So things like some COVID funding, where we have our allocation identified, has flipped to receipt of funding will be based on spend. That is being actively discussed with Welsh Government colleagues to get clarity on that, and hopefully we'll have that clarity before the month 6 report needs to be submitted. We are and have been consistent throughout the year, been very clear around our financial plan and our targets, assume full receipt of the anticipated. In terms of pay spend, we have seen a drop in month 5 from month 4. Some of that's due to the payment in month 4 back pay for pay awards. Our run rates, as Nicola mentioned earlier, are broadly the same though. We have seen some creep in the variable pay costs for month 5 around mental health and medical posts. Again, just touched on in earlier discussions. In terms of non-pay, we've got a step change in our spend for non-pay, but that was related to RPB funded developments, approximately £2 million. So that didn't cause us an adverse position against our budget plan. And in terms of savings, the £51 million plan established through the IMTP, we've got forecast delivery of 30 million and obviously a £21 million gap then, which is described as reds in the paper, red rated schemes in the paper, which is where we need to make inroads into to support our financial forecast. In terms of operational impacts on our financial position, and again, a lot of this has been touched in the debate so far. So demand and acuity remains at exceptional levels compared to previous years, particularly in urgent care and how that's emerging to some degree in terms of bed pressures as well. Delayed transfers of care continue at very high levels, approximately 300. Cost of those, if that was to continue all year, is in excess of £20 million. Our enhanced care is a reflection of acuity still running at about 17%. And in terms of variable pay, we are seeing continued vacancy cover requiring variable pay solutions of 2.7 mil. We've added in, following a question last time we discussed a sickness level graph and table, which identifies a cost in month 5 of about £500,000 related to sickness levels. In terms of CHC, we do have a net reduction in places, and there's been some further work in terms of analysing our case histories to look at forecast costs. So that's taken a favourable benefit into the forecast of 1.7 million. We're still delivering treatments and outpatients and diagnostic services that are for month 5 at or above planned levels. So that's a positive in terms of service delivery. However, a key risk for us outlined in the paper is prescribing. And in context, our price growth as a cost per item is now 46 pence more than we presumed in our financial plan. And that's for every item prescribed, and we prescribe something like 46,000 items per day. So that'll give you a context of why that's driving a £12 million deficit risk for us as a forecast. In terms of the overall, the key message from me for today is note the risks around the delivery of our forecasts. We need to look at where we could go further with savings and mitigation plans, which is an ongoing process anyway. And just to note, the mid-year review of 6 will include a consideration and reassessment of our ambition and delivery target for the year end.
Thank you, Rob. Questions, comments to Rob? It's a very worrying and serious position. And I understand very well the effort that has been made throughout the organisation to restrict spending and not to affect patient care, because that would be acceptable. But we are well off course and we might be asked to save more. And we are obviously going to have to redouble the effort to enable us to meet the needs of the patients, but also stick within our financial envelope. I don't think anybody's coming over the horizon to bail us out anytime soon.
It'd be so.
No. Okay. Paul?
So what can we do to help and support the executive team with regard to this? Because it's absolutely essential we make sure that we do not end up with a deficit of £112 million. So what can we do to help and support you to achieve that reduction?
So obviously our target is the 112, and at the moment we're offline in terms of line of sight, although the best case assessment, if we could convert our, as I described, red rated saving schemes and to go further, actually we need to find of the order of over £30 million now in the second half of the year. I think in terms of our direct actions, we need to revisit all our plans to make sure we're accelerating delivery. Be very, and this is happening currently, and be very clear on what we can assume in terms of start dates for things like savings plans, just to sort of maximise the amount in year. That's a significant issue for us to manage. And what I would suggest the ask of the board would be is to just be aware that there may be, in terms of next steps, maybe things that need to come here, and we may need to revisit some of the previous decisions made. But at the same time, as a board, be very clear with that, what that means in terms of wider implications, not just the money.
Yeah. I think it's essential we have those plans in place. Month 6. The time moves on very quickly. We're not.
Yes.
We need to, at this stage, be absolutely clear that we intend to make sure we don't have the deficit, and we have to escalate plans as necessary. And I think it's the worst case scenario would be if we go into special measures or whatever the term is with regard to the monitoring, because that just means that we have very little choice. It's all made for us. So I think it's crucial.
I think, Paul, there's an issue around, you can probably second guess what, if we go up the escalation, what the commentary and the observations would be. So it's in our gift to make sure we're dealing with those issues.
Yeah.
Currently. We've got opportunities around efficiency. We need to implement very, very quickly now. Yes. We've got the focus groups through the Value and Sustainability Fund, which again are part of the mechanism to try and catalyse some delivery. And again, it's just, for me, a lot of it is acceleration. But at the same time, I do think, given the quantums we're talking about, there's likely to be a revisit of early decisions.
I think it's essential that we support the executive in delivering really efficient and effective services. And there should be no wriggle room on that. Kelly?
Yeah, I was just going to say about the amber in particular, and I think last month we also had the ambers were not delivering on time, and obviously that, so I suppose that's the concern, and what do we think the likelihood is that is going to be realised? And I know you're going to be doing in terms of accelerating. The other point I was going to ask was around the people the 350 inpatients here, and the percentages, which is within the gift of the health board, as it were. But I wanted to just check with Jenny, presumably the 27% which are health related, but there's 29% of patients that are, if you like, waiting for family and placements, that choice thing which actually has been suspended. And will the discharge, or is the discharge board looking at those? I'm just thinking about a personal circumstance some years ago when my mother was in hospital. We were waiting for, we actually had quite a lot of pressure, not from a AB hospital, to take one of the places that was available locally, which didn't. But that was a very difficult conversation, but won't let us. And I just wonder how quickly that is happening, because it is difficult.
I think there is, so my sense is that there's an element of risk averseness in our clinicians. And the reason for that, I think, is multifaceted around particularly professional indemnity liability if you discharge something and something happens at home. I think as well as what Leanne's described around how we, and I would say, feel that we have enacted changes. There has been positive progress in some areas around discharge, whilst the overall number hasn't improved. I think if we hadn't done what we've done, it would be worse, because we've done a huge amount of work in Newport in particular and with membership. But I think there's a sense of, and the reason that myself, James and Peter have put comms out is that they won't be supported, that clinicians won't be supported if they make these decisions, if they more proactively work with families to say, actually, that care home may be where you want it eventually, but actually we need to do something in an interim that's completely different. And I think it's a hard and slow process to get that change, but I think the patient safety days will challenge some of that. I think the new data system that we're going to be putting into place will help us with some of the data. We've now got things like weekly walkarounds and reconciliation of the data with all of our local authorities, and that gives us the ability to challenge. And I think some, as I say, with the patient safety days, we'll be able to more actively challenge that in the moment, because sometimes it's saying to people, yes, we understand you are worried about the risk of this person going home today, to perhaps a placement that is not of their choice, or a back into their own home with only one package of care, not three. But actually the risk of them being in the hospital is far greater. We're seeing patients who fall and have head injuries. We see patients who end up on the palliative care pathway because they've stayed in hospital too long. So I think some of it is about presenting the facts and the data, because clinicians love that. Some of it is about saying, look, myself, James and Peter have got your backs. We will support you if something goes wrong. And some of it is about challenging families to say, actually, why would you want your relative to be in this environment? Because they're at greater risk from infections, falls, and a number of other areas of deconditioning. And we are I think we are the first health board in Wales to try and come up with a deconditioning metric. There's nothing nationally, there's nothing in the UK where we're really starting to challenge those perceptions about they're safer in hospital when they're not. And there is something in a win-win with the local authorities. We've seen through the home that we've reduced packages of care. That's not necessarily in our financial benefit. That will be a benefit for the local authority. So I think it's pulling a lot of this together with some rapid change in the patient safety days that will give us a compelling narrative, I think, to do the next steps, which is be a little bit more directive, be a little bit more planful around how we get some of these patients back to where they should be, which is their own home in most circumstances. I think there's more to work to do with the care homes. We have a great relationship with our care homes. We have great monitoring of performance and quality. And Leanne and I met with the person doing the external review, and she fed that back, that we've got that good relationship already. It's how we capitalise on that, perhaps to enter into block contract arrangements that are done in a more planful way, that say, actually, we're going to use your beds and we're going to use them more proactively. It sustains the care home market, but gives us an opportunity to place people more quickly.
The problem is, though, Jen, is we're still, seems to me, focused on this push model where we're pushing people out. We're not grasping that actually what we need is the communities that will actually pull people.
Yeah,
I think that's part of our problem. And an awful lot of our work has been about how we push people.
Yeah.
But actually the community should be saying, we want these people back. And there isn't that sense yet, is there? It's happening in some places, but it isn't a general acceptance that people are better served at home.
I think that's changing, Phil, certainly through the work we're doing in the link up between redesigning services for frail people and the discharge space. And certainly in the Neville Hall pilot is very much with Monmouthshire focused on that pull model. I think you're right. There's something about how do we have the push and pull model, which is about, you know, really saying actually our community and CRT teams probably know these patients best. We need to get them in the environments pulling those patients out. It's part of the reason we've located our nurse assessors in the hospitals, because again, they'll know their care homes, they'll know the opportunity that exists. And it's about that sort of whole system, push and pull for the right patients. And we're not there yet, you're quite right. But I think we know what we need to do. I think we've done the assessment. I think we're testing a lot of this. And I think we now need to spread at the pace.
Okay. Lots of work going on, but we've got to keep the foot on the pedal, really.
We are.
Yeah.
We are, Lee.
Yeah.
And myself and James need to got on the pedals.
Smooth the floor.
Yeah, pedal.
Any further comments? Yeah. This, oh, dear.
Okay, the risk report is kind of continuing the evaluation as last week has been updated. This is work in progress, as you can see, and you'll have seen since the last meeting. It's been further developed to the 10 strategic risks. And we continue to work with each of the strategic governors to ensure fully capturing mitigation risks against each of those. So, some time, I'm just happy to take questions on any of the risks raised specifically, or the development of the strengthened assurance.
Are there any questions?
I ask in terms of strategic risks across the whole of health boards, is any joined up thinking about how the risks tied in with the ministerial priorities, tied in with budgets, but having sort of one plan to try and address the budgetary concern? It seems to be as if lots of things going on in sort of separate areas, but no consolidation. Just wonder, I mean, not just this thing, but the strategic risk, a sort of a general question, yes, from more sort of Wales model.
You mean on a NHS Wales wide risk?
Yeah, I'm thinking about, obviously the key issue at the moment is finance. And therefore that's the huge risk for the entire model. And you're thinking suddenly we're developing a plan, but on top of the plan, there's ministerial plans. And you're thinking, okay, that's going to mean one, you know, we could have a plan. There's a slight directional change because we may be asked to look at a particular area where we have perhaps thought of that, or we have thought of it, where there's more. I just wondered if there's, you know, any opportunity to have that sort of one conversation, one plan, one budget sort of.
So the strategic risk register assesses the risks that would potentially impact delivery of our strategic priorities. Yeah. So that's really our annual plan, INTP plan. So that should capture the integrated nature of that plan. So finance.
I think that's within. I'm just thinking. Probably the question is, perhaps for another day, perhaps, but it's just as to whether there's one conversation to try and reduce the problems we're likely to have if there's more ministerial priorities coming in or other things coming in offline asking for us to do other things.
I'm not sure how much of that is in our gift.
Right, just a question. I know your chief executive, you may have your chief executives meeting.
Yeah, we obviously meet as chief executives and share, you know, the risks we face in, and some of the big risks will be discussed at the National Leadership Board. But I don't think the NHS as a whole has a risk register that is an aggregate of the other health boards, but interesting point.
Yeah, I'll leave that with you there.
Yeah. Well,
right.
I think it's the nature of statutory bodies within a system.
Okay.
Anybody else got any questions? I just wanted to just say about the actual individual risks and the sort of risk on a page, which sort of goes over to 2 pages, but I think it is helpful to identify particularly, you know, the controls and where there are gaps and that sort of area, because I think that's something through the Finance and Performance Committee that we've been asking, the risk committee we've been asking quite a long time. So and it's, you know, it's quite in a way refreshing to see, you know, that areas you can have them determine. I think it's where we have wanted ways to get it. Yeah, we're getting there now. So when we read something, we're thinking, well, I don't really understand that, but actually, yes, you can see. So
it is a work in progress.
Yeah, I appreciate it.
But I think the structured approach should help, in particular for the committees, to be focused on those areas for which it's got responsibility.
Okay, right, we're happy to receive that. Yeah, thank you. And next item is the board self-assessment. So is this Rani? Yeah,
thanks. So this paper presents a summary of the board's annual self-assessment of its effectiveness for the year 2022-23. The board held a session back on the 28th of June, and so this paper summarises the outputs of that session. The board used the well-led framework to assess its effectiveness against 8 key areas, and of those 8 areas, 5 were rated amber green and 3 rated amber red, with areas of development needed in each of those 8 areas, and they're set out within the paper. I wasn't going to go through any more detail, but happy to take questions.
Anybody got any questions on that?
I think the process has been incredibly helpful, and it's really consolidating it into a sort of one plan, and I think it's been some great work.
Thank you. Just to add, sorry, just to say, so committees and the board's committees will now start to undertake mid-year self-assessments. We've commenced the process for that with some that are due to meet shortly, and that can then inform also the end of year board assessment to be focused on more broadly the board's business.
Thank you. Okay, thanks for that. Next one is the executive committee chair's report.
Thanks, Shirley. So the standard report is updating on some of the activities of the executive team and with other leaders to over the last few months. Just to pull out a couple, in terms of the quality and safety agenda, I'm quite pleased to say that we've now launched the Civica. We've been talking about it now, which is our patient experience platform, citizen experience platform even, and we are starting to see some of the survey results of that, and that will be further developed. I think it's a really powerful tool for staff in particular to get a more balanced feedback rather than sometimes just dealing with complaints. So you know, and they do get compliments, but it's a kind of much more holistic approach. We've picked up briefly some of the challenges we face around mental health, and we've got a really clear improvement plan, which we an executive team get a weekly update on, which is really positive. And then the core learning committee, and we've got quite a lot at the board, haven't we, around all of the training requirements, what's mandatory, what's not mandatory. So pleased that we've now agreed the core learning committee, that we're calling it, which has got that kind of oversight around the different requirements around training. So more progress on that will be shared as that develops. And then I was just going to briefly touch on WCCIS, which again we've discussed, and Paul is obviously working with Leanne in terms of the division, but also at a national level in terms of the future of the system. But more importantly, how do we get the system working effectively for us in the health board at the minute, recognising some of the risks that that's facing for us. So we had a particular briefing on that and understood the challenges, again, you alluded to earlier, and we're working through that as well. So they were the only issues I was going to pull out, but happy to take any questions.
Any questions? Next item is the Regional Partnership Board update.
Thank you. I won't spend too long on this, because I think most of the items we've already covered in the chair's update at the beginning of the meeting. So this is just an update from, I was going to say recent, but the July Partnership Board, recognising we had a board meeting last week of the RPB. So I'll just add a bit of update to the paper post that. We've tried, or Chris has tried, to keep reminding us of why we're doing this partnership work with a bit of a case study in terms of some work that's happening in the assistive technology programme. It's a really brilliant programme, loads of great stuff around smart technology, and I think we need to think about how we're shining a better light on that really as we move forward. But in terms of the substance of the report, the July RPB considered the end of year report, and some headlines are shared there. But in terms of the other two sections of the paper, I just wanted to update from the meeting from last week on the 19th.
The chair alluded to the governance review. This was received formally by the RPB on the 19th on Tuesday, and I think we had quite a robust discussion. Those who were there around some of the learning reflections process itself. And as the chair pointed out, in terms of a response, sort of a twin track approach, one recognising that we have as an RPB more to do to really be clear on what those joint priorities are. So, and more to do to strengthen and revisit our relationships, recognising that there's been turnover both within the health board, but also within particularly the social services portfolios in local authority. So commitment to get in a room together to review that, whilst at the same time mobilising that task and finish group to 13 recommendations, which range from risk management, business processes, escalation and reporting. And so just sort of a heads up for one of the reporting recommendations is around, so post every RPV there is formal output, and we will use that then to inform the paper to you rather than us pulling it together, which is what currently happens. So a lot of work around the governance review. Similarly, around the strategic capital plan and strategy, this the paper updates on the process that's been followed. It was received, the draft was received in the RPB. I think it's fair to say, it's recognised that a huge amount of work had gone into the development of it, but there was still some sort of closing of the loop to do in terms of taking it back into those the supporting partnerships to ensure it sort of reflects the key messages. So it's gone, it's sort of been, I can't remember the word we use, endorsed through the RPB, recognising that it's going back into organisations and back into those partnerships, and it has gone into Welsh Government. So personally, it's the first time we've, I've only been to 3, but there is a strategic framework now around which we can hang decisions around and where we want to take the investment. So that was positive. There has been the July board received a evaluation paper on the integrated winter plan that then also a part of it came to this meeting. There has now been work on the winter plan for this year. Due to the size of the agenda, that wasn't considered in detail last week, and another follow-on, so part B of that meeting has been arranged for the 9th of October, where the RPB will pick up the winter plan for this year from an RPB perspective and the finance report. So I'll pause there. I don't know if anybody else who's there wants to do anything. I think it's fair to say that we recognise that the governance review has given us a bit of a platform to move forward as an RPB, but we've got work to do on sort of agreeing those key priorities and strengthening the relationships as we move forward.
That's what Hannah.
Yeah, I wanted to unpick that really, because we're now in sort of, that was only 19th of September. So how do you feel? Is that what was the final report that said you couldn't receive on 19th of September? Do you feel that is going to be really helpful to put structure to the whole report? Yeah.
I think so. There was. I mean, I'd be lying if I said it wasn't sort of a robust conversation around it. The RPB, there were some national timescales around that going in, that the RPB we've delayed putting in to try to address it in the right way in terms of engaging with the partnerships. It's been led by one of the sort of the housing partnership, but I think it could stand us in a really good place to move forward on. I know not all RPBs have put them in, so whilst we really sort of criticise ourselves in an RPB for submitting it late. I'm not aware that other RPBs haven't submitted at all. So, but I think it gives us it's a strategic framework with a detailed plan. But I think it's important to say every sort of case coming forward has to sort of stand on its own in terms of the benefits, the investment through a business case process. So progress, but there's always more. There's always a bit more to do, and it's really important that we internally now review our plans and align to it, and we've committed to RPB1.
That's helpful.
Any other questions? Thanks very much for that. Next is the joint committee activities.
Yeah, so the first one, which is was the risk report. It's fairly self-explanatory. There were two specific issues in terms of taking on the future question of neurophysiology services for Wales, because it has sat between the health board MTAs, and whilst there's debate about specialists, it fits much more when you've got that kind of oversight. So that was agreed. And likewise, the on safer nerve stimulation and the process for risk to take on the commissioning of these services as well. And again, makes sense to use that kind of structure we've got. Then sometimes you end up with different health boards trying to navigate and can end up with a bit of postcode prescribing, which scope lottery, I suppose. So that's good. And I think a lot of these issues will be reviewed as part of the National Commission work that's going on at the minute as well. So they were just the two further detail.
Anybody got any questions?
I could ask about the, obviously we, in terms of our budgetary position, is that we have to make significant reductions. What's the situation with WISC?
So there's a few things. So as part of the plan, we obviously needed to put some of our funding to increase our contribution to WISC as part of the financial plan. But we also asked that they try to identify a further 1% saving to help towards our savings plan, which they are working on. They're not quite there yet, but there's a bit of a line of sight of how we could get there. As part of the work the Welsh Government had asked, they've also submitted choices into Welsh Government that we could consider as well, alongside Welsh Government, around things that could help reduce expenditure. They were very much around policy decisions on particular services. So that's currently kind of on hold until we've got further information from Welsh Government on that.
Yeah.
But I think, from the discussion we've had, there are things we may need to consider as health boards anyway, given where we are financially, irrespective of where, for us to have the conversations with Welsh Government. But I have put forward a number of suggestions of where we could look.
Thanks for that, Nicola. Next one is the
East Front.
Yeah.
Yes, so the East report, Jen attended the meeting on my behalf. The summary is there. I think what we are seeing an improvement in performance across the board, including our health board, as Leanne alluded to. We have seen improvement in handover times and response times at certain areas. And as Jen said as well, as a piece of work in terms of looking at a national level and what we are doing with WAST around a kind of conveyance rate as well. There was obviously an update as well on the emergency work that's going on as well, which is included. I don't know, Jen, if there's anything you wanted to add, or
just to say that there's going to be a workshop with all of the health boards and WAST around future of alternative models of care, as well as our internal one to AV.
That's about the budget as well, as to where they are with regards to contributions and actions.
I think all of the trusts have been asked to see, so they were all focused in a balanced position, but all trusts and other health organisations such as HIW and DHEW have all been asked to look at what opportunities they've got to underspend and what some of those choices would be to contribute to the overall financial plan. That's right, isn't it?
Sorry.
Yeah.
It is just to add to that. I think it's probably worth noting that the Wales wide Welsh financial position, the deficit was driven by health boards, with all the other organisations broadly being balanced. Hence, as Nicola said, now the push and the request to go further. I think, given that the health boards fund a lot of those other organisations, there's a question and reflection there.
Yeah. And we've tried to make sure there's equity in terms of some of the programmes we host, in terms of places like WISC and EASC, in terms of the control environment we are now having to work in terms of vacancy scrutiny panels and attending conferences or whatever. There's an equity across the system as much as possible.
Yeah, well, that was what I was
trying to. That is happening. Yeah.
Good. Thank you.
Okay, that's great. Thank you. Now we go on to key matters from committees. So my papers, the first one is Anne's chairs that committee. I does anybody else want to speak? Is there anything particularly that anyone wants to raise? Which wants to report? Are we happy with that? Okay. Next one then, Ewan.
Yeah, nothing to add to it.
And we've got patient safety and Pippa would normally present this. Does anyone feel the committee they want to raise?
No.
And the mental health is the same as Pippa. Is there anything off that one?
No.
It's not here. So the finance committee.
Just to highlight, it's in the report, but there's some concern about the deliverability and costings of the radiology informatics systems procurement. I think we're expecting some update on the costings towards the end of October, and we'll follow up in committee.
And obviously we've got a couple of in terms of the NHS shared services partnerships committees. Are there any comments in relation to those? That paper. I think then. Most finally, sorry.
No, that's fine. Yeah. If you're happy to, if the board is happy to approve a motion to exclude members of the public in the press, then we can stay in committee.
Okay, happy to do that. Are you happy to agree with that? Thanks.
Take 5 minutes while we do that.
That'd be great. Thanks very much.
Yeah.
Yeah, so just thinking outline the timing.
So we